MEC and your team, as well as the other officials that are part of the legislature. May I take this opportunity to welcome you to the Portfolio Committee meeting. And I understand that you have been waiting outside. For sure, the person that we said to you to say, please give us some few minutes has come to you. And MEC will say, oh no, that is accepted that when she comes and speak. Without much ado, I just want to say welcome, as well as say this meeting is officially open, and draw you to the agenda of the day, where we are going to start with the implementation of the House resolution that are outlined in the agenda as you see. And secondly, we go through our normal second and third quarter performance report. And we'll be done with the day. May I also make you aware that we will be live. There are three other people who join us who normally are not sitting with us here through our stream. And of course, the first report, I would suggest that you just restate what was required and give feedback on what the progress is, so that we save the honorable members' time. We know from the performance perspective, if you are asked to clean a dog, the first thing is to say, I was asked to clean a dog, and we see the dog clean. Before you say many things, we'll tell you all whether we want explanation or not. But the first thing should be the first thing, and others will come later, just to make sure that we understand whether the dog is extremely clean or extremely not clean. Honorable MEC and HOD Protocol, that is understood. The last time the HOD was understanding what I'm saying, she took shorter time. Without much ado, well, there is a ritual that always happens here. I don't know if I must do that. Introduce yourself. I don't know. Can you allow me that we go straight to business? Yeah. Thank you very much. I can see the MCs also agree. If anybody wanted to include that person here to take the floor, you say that this is a new found and you don't know this person is the name he said and therefore, may I now take this opportunity as I welcome you, Honorable MEC. I'm also giving you the mic.
Thanks very much, Honorable Chair, and good morning to yourself, all the honorable members of the Portfolio Committee on Health, and all the members who are present here today. Chair, let's appreciate the moment that you have given to us, and also appreciate the call for us to come and account, as it is our responsibility to do so. As you have requested, Chair, we are not going to waste time. We will get straight to the point, and if you allow me, I will hand over to the HOD, Dr. Ndwamatu.
Good morning, Honorable Chair, honorable members, MEC, and the team with me. I'm going to start with the first tracking resolution, and I'll mainly focus on the areas where there hasn't been full implementation. So the first issue is about the multi-sector team that is dealing with teenage pregnancy to organize a meeting and then invite the portfolio committee. So currently where we are, the teenage prevention strategy has been adopted by EXCO, and the implementation plan is currently underway, and it is to be completed in this quarter. We are working together. The leader is the Department of Social Development. And then the other issues that we had to report on, we have implemented the issue of immunization, where we did the catch-up plans, and we were tracking the performance, and we've been improving up to May. However, as you'll see in the current performance reports, we had a challenge in that there were the vaccines were out of stock at the where we buy. We couldn't get for about 6 months or so, so that has returned us back to the where we are. The issues of EMS, especially the staff, the cars, as well as the CAD. The CAD has been implemented, it's operational. Ambulances we continue to procure, and we'll still be giving, we will be delivering some now in April to various stations. And all the posts that have been advertised, they've been appointed. There are just few outstanding that are not yet submitted. Then there was an issue with regard to how we are dealing with legal matters, and that we have submitted a report that talks to the progress so far since we have received the SIU report, which detailed the cases that they found that the people have passed on, and those cases the department is currently dealing with the state attorney in order to remove them from the contingency liabilities. The issue of EMS colleges, we have been dealing with that one, especially the infrastructure issues, and a lot of work has been done. And we will know the final reports towards the end of the month, towards the first quarter, because many of the projects are just currently concluding as we speak. And then we have a number of infrastructure projects that have been done and be completed, and the list has been attached there. And then the issue of legal issues that we have submitted a report in there with regard to the first resolution. I think the majority of the issues were how we were handling those legal issues, and we have submitted the reports on how those issues are being handled, including how we are working with state attorney despite the challenges, the areas. And then maybe I can also quickly report on the issue of a panel of legal attorneys that we have sourced to look for to assist us in terms of dealing with the medical legal issues, especially that the state attorney has not been able to assist with us. So the previous contract, we couldn't conclude it. We had to go back to re-advert, and then after re-advertising, we are currently evaluating that contract so that we can get a legal team that will assist us. And with regard to the Solicitor General, where previously we said we are writing to them to allow us to do that, they have responded and gave us a person, I think it's not so long ago, to deal with, so that we can deal with the local state attorney challenges with a specific person. So we have been given that person, and we are in the process now of meeting with that person, and to ensure that we are able to move on the issue of medical legal and contingent liability. I think those are the main issues on the first resolution. Majority of the documents are mainly the annexures to support that resolution. Then I'll go to the second resolution, which is what we have reported on with regard to the unannounced visit to the various facilities. So there were various facilities that we received reports on following the portfolio committee visits to those facilities, and a number of issues were raised for each facilities. Some issues were common along all the facilities, issues of staff, shortage of staff, And as at the time that we gave this report in October, some of the issues were already resolved, like the Mangweni Hospital. We have appointed the CEO, the Director of Corporate Services. So those people were appointed because the advert were already out, and we are now able to say some of those issues have been sorted out in terms of the vacancy. Then the infrastructure issues, there are a number of them. There were issues of the laundry at Mangweni, that it is not yet completely resolved, and the infrastructure team is currently working on it to ensure that we are able to close that one. And the only outstanding issue why we could not close that and conclude the laundry to be operational ourselves is because there were still final accounts that we had to deal with Public Works, and there is a meeting planned for tomorrow together with Public Works to look at all the outstanding issues. This includes this hospital, Mangweni, and it includes Philadelphia Hospital, specifically with the laundry machines. So those are the final accounts. Once we have received them, then we are able now from our side with our own infrastructure team and our own panel of contractors to conclude those issues. And then there were a number of infrastructure issues that were raised across various facilities. I can report that our maintenance has been around most of the facilities in the province, upgrading and refurbishing. And most of the infrastructure projects that have been commissioned within the budget that we have, they are being concluded in this month. So we have not been able to have a final report to say this has been done. The only one that I'm aware has not yet been done because there was no funding allocated in terms of the facilities that have been presented here. I think there was a clinic in Mopani, Hlaneki Clinic. It is one of the clinics that the infrastructure has not yet been done, but for majority of the facilities, until we get a full report on how the projects we have commissioned are concluded, I'm not able to say where we are. That's where it is saying, at the time that we wrote the report, it was partially implemented, but currently, once we have gone back to the works that we have been doing, we can then conclude on them. So I'll just quickly also move on to, I think EMS College, it was not only infrastructure, it also referred to the issue of us opening the college in terms of the curriculum. So I can update that currently we are twinning with a college in Gauteng called Libone EMS. We have already met with them. They have agreed to start sharing their curriculum with us, and there are some courses that are going to start very soon, especially the basic life support. We have already committed even in terms of funding towards those courses, so that the college, while they are finalizing the memorandum of agreement, we are adopting that, and then they will be training under we will be their satellite training, while our own accreditation process is being finalized. So they are assisting us to do that, and we have already signed to say we can go ahead with that one. Hlaneki Clinic is the one where we haven't done. And then the other, Giyani College, we continued to work, especially with the infrastructure. They've continued to work, as I've said. The infrastructure, there were a lot of work that has been commissioned towards the end. And then the issue of the library and the books, the team is not fully implemented. The team is still working to ensure that they are having linkages between the other colleges, Sovenga, where we have a larger library, and Petersburg Hospital, so that they can share the resources that they have in terms of books. And then the issues of Wi-Fi, those ones are being sorted out as well. It's not fully implemented. because they've had to buy additional routers, and so those will be implemented. I'm going to pass the infrastructure issues because they were all partially implemented. We are still awaiting final report. Majority of the work was done in the last quarter. And then Letaba Hospital, similar issues of HR. We have appointed doctors. We have appointed 4 professional nurses and some radiographers. So that has improved from the last time when we met. The department, in terms of acting position, the department has been doing that, and we have been appointing, especially the leadership positions, those ones we have worked. At the time that the committee visited, the boiler was not functional. It is now fixed. Everything is working in terms of the boiler. And then so we had an issue of the renal clinic as well as the ICU in the Letaba Hospital. It is also one of those that are going to be functional in the first quarter of this year. They are in the final stages of completing that work so that the patients will be dialyzed at Mopani in terms of that. So the things that are similar that I'm picking up from one college to the next, they are similar. We are dealing with them. And then with regard to the EMS station, Libuahomi specifically, the one that is inside the hospital is fully functional. Most of the issues that were raised have been sorted out in terms of that. The Libuahomi EMS station that is outside, that was being built, it is part of those ones where we are going to be meeting with Public Works to discuss the final account in terms of us, as we cannot move until they close that account. Otherwise, from ourselves, we are just waiting for that process, and the meeting is tomorrow. So that is with regard to those visits. I'll move on to the next resolution, the one. This is the reports that we were requested.
The first one, you say how many you resolved?
I will have to count. There are many. But I would say, looking at it from my eyes as I was going down, it looks like it's 50-50. The ones that are fully implemented could 50%, but the other ones are partially and not, could be around 50%, but I can't say until I've literally looked at them. Especially for the second one that I'm looking at. For the first resolution, it was only one that was not resolved, the one for inviting the committee. The rest were fully implemented. And some of them are ongoing process, but what the committee has requested has been done on the first tracking tool. The one for the visit is the one that I'm estimating 50-50 until I can actually look at it. The third one is where we were requested to provide reports. The committee, we needed to submit reports, and then the first one, it was the issue of consequence management with regard to the irregular awarding of coal tender by the department in 2024. So that the consequence management is underway as we speak. They are almost at the final stages. People who were involved have been subjected. They are now at a reporting stage in terms of the investigation. Then there was an issue of Wombath Hospital. wherein we are having paupers burial. And then at the time that we were reporting that time, there were municipality had buried 5 bodies, and there were about 47 bodies that were still there, and we were having challenges in that the municipality was not coming on board. We had several interventions that we have made, and the last intervention that we have made now is when we now had to write to the MEC for Coxta. Our MEC has written to the MEC for Coxta so that they can take it serious, because it's not only this facility that we are having challenges with bodies that are in mortuary not being buried, who have been declared to be paupers. So that was around, could have been the beginning of March, when after we exhausted all our efforts between myself and the HOD for Coxta. So we are bringing in the MEC to assist in this regard. So with regard to the APP indicators, where central hospitals and provincial hospitals, they were only reporting one indicator. Our reports now include those. So as you will see when we present the report, we are also showing the performance in certain areas that the committee requested for the provincial hospital as well as the tertiary hospitals. And then we have attached the report that we have submitted for condonation of the irregular expenditure following the report from Office of the Premier that they did the investigation, and the current disciplinary process that we are doing. So for that, because of that, we are now in the process. So the rest of the documents that are following in that is the investigation report from Premier, that was the Office of the Premier, that was done with regard to the tender. So we have attached those reports. I'm just moving on to find the next one after the reports.
Members, you are following? Yes, we are.
Yeah, it's good, Chair.
No time for questions? No. I just wanted to...
So yeah, I'm just passing because majority of the issues that are here is when we initiated the consequence management, that was around October. So all those things that we have attached there, we have attached that report of the investigation, as well as the findings by the AG. So those are the ones that are passing, which has led to that contract being deemed to be irregular, and as well as now us constituting consequence management. So those are the majority of the reports that are there. And then the one that I've already spoken about is the other attachment. It's when we were, as the department, writing to the HOD of the Coxta. So those are the attachment. And I think the last one was now when we were giving a report on the report of the provincial hospital targets performance. That was the last one we have attached. So that was the tracking tool for that one. Then the last tracking tool for the resolution, these are the resolutions that emerged from the workshop as well as site visits that came to us that we needed to respond on. I think some of them we have already responded on because they coincide with what I've reported before, the issue of EMS college, specifically the issue of CPD and basic life support courses that we are now dealing with, that we were planning at that stage. They are the ones that I've reported that we have already met with the Libone College of Emergency Services in Gauteng, and we have already commissioned to say we are going ahead, we will be their satellite. That is the work where we are now. So that was the last, so that is the EMS college. And then there was also an issue about the structure for the EMS college in Limpopo. We have just finalized the lower structures, the structures, all of them, including the EMS college. We had submitted them to Office of the Premier for concurrence so that we can implement as from the 1st of April. So, however, we are also having challenges with labor in that we are currently relooking at some of the issues that they have raised with regard to the structure. And that, when we talk to the college, it speaks to also the staff of the college. I can report that those posts that we've vacated in this current financial year, we have filled them. For example, with the college, this is the nursing college, 3 lecturers were filled, 1 general worker, or 3 general workers posts that were on advert, they are all filled, and then an assistant director for corporate services was also filled. Then the issues of maintenance, I've already spoken to them. The issues of library, I've already spoken to them. And then one of the issues is about the issue of ICT infrastructure at the college as well as the nursing college. I've also already spoken to them that we are procuring 25 routers. We have procured 25 routers through the RT15 contract for the 5 nursing colleges. And at the time that we wrote, it was partially implemented because we had already done that process, and we still have not verified if we have received, but from the report, almost all the things that we have procured, we had received them. And then the issue of student management system, this one, we had commissioned that it should be provided. We are now participating with the Northern Cape, because all provinces now have found that they already have the contract, and that is the work that is happening to ensure that we participate in their contract, because it has been found to be working. From our own, we struggled as we were trying to put it in place. The SRC is in place in the nursing colleges. That one has been done. Bulk backup for water and electricity at the nursing colleges and the EMS colleges. For EMS college is done because it is within the hospital, it's 100%. But for the nursing colleges, that is part of the infrastructure that has been happening, especially towards the last quarter, that we can only report on it once. So for now, it is not fully implemented. I can only report on the issues of infrastructure that we have been undertaking in all the colleges. We have only been seeing progress in the form of pictures. We have visited some of the colleges to see that the work is being done. So there has been a lot of work that has been done, especially with the infrastructure. Waterberg campus, the only one that has not been fully completed is St. Rita's, but the issue of electrical cables that were stolen, and the main issue which was making that campus not to be okay was the issue of electricity. So we have repaired that. It is been repaired now. There's now electricity at the college, but other infrastructure issues are still being attended to. The Lokong Hospital, just quickly as well, is the same with the staff. There has been filling of posts, including the post of the CEO, which was highlighted. And then the department continues, depending on the funds that we are having, then we are able to fill some of the posts that we are having. So the issue of health technology that is to be acquired in facilities, we normally, as a department, have a central place. However, at the facility, they are to revive the health technology team that will assist, especially with those equipment that are to be bought at a local level, but majority of the equipment are bought at a central place, and certain ones have been provided. The oxygen tank has been repaired, the gas bank is repaired and serviced. So some of the issues, especially the issues of water filtration, they are still work is still underway, they are not completed. The issues of theaters, the theater has been serviced and is repaired, it's working. I think some of the things, Philadelphia Hospital, similar issues of staffing where there has been several appointments that were done. We have listed in the report the appointments in that particular hospital. However, not all posts could be filled because of the issues of funding. However, those ones that were funded were all filled. There were additional funding that was provided to Philadelphia Hospital to enable the maintenance of issues that they were raising. So they have managed to do a number of projects, and those projects we still have to receive the final report as to the progress with regard to those projects. The issues of fires, we have now submitted, a fire assessment is complete, a fire plan has been prepared and submitted to the municipality, so we are waiting now for the municipality to come back to us with regard to us implementing that plan. So the health technologies that have been listed there, they are all in plan. For example, a CT scan is in plan pending the renovations of the structure that is there. The digitization of radiology is being done across the province, so the PACS is referring to that, so that will be done as part of what's happening in the entire province, including the provision of the other health technologies like the mammogram. So we've also provided a report on certain issues which were not done at that time, like servicing, all those things were done. I've mentioned the issues of the laundry machines earlier when I was talking about Mangweni Hospital because they are similar. So majority of the things were maintenance issues that were currently being undertaken during the fourth quarter at the facility. So some of the issues, once we have a full report, we will be able to report because the projects have started but are not yet completed. So that's why for some of them we wrote partially completed because we have commenced. However, until we get that final report, we are not able to report that it is fully completed at the moment. So that was the last tracking tool. Thank you, Honorable. Let me see.
Thank you, Chair.
Thank you very much. Your conclusion on the not yet implemented partially and fully implemented, which one do you want us to discuss? I'm just about to open the floor, but I wanted to be clear about, because I don't want an honorable member to enter into a terrain that will not assist us. Partial one in particular. I don't know whether you want us to enter into that or you want to say you report some. And what do partial mean?
Yeah, Chair, I think.
Percentage of anyway you can define it.
Okay, thank you, Chair. I think maybe if the honourable members agree, Chair, is that if we can then be able to provide a report when we have the report, when we have completed the projects, because the partial part that we mean that the projects are in progress when we go to facilities. Yes, it's work in progress. So now we are saying we're waiting for them to finish, then we can have a proper report that now we are done with this project, it's completed, and this is what we have done. We'll be able then to outline it. But for now, if you go to the facilities, you'd find that there's work that is happening there.
Okay. That's why, honourable members, I think the department presented a resolution and how please assist me on how to process that in a big number of the resolution are partial. Let me see if just explain what does that mean. Let me start with you, we'll end with you,
Sorry, Chair, we've only just got this presentation. We have not had, it only came through last night apparently. We have not had, am I correct or am I wrong? Okay,
no,
then what am I looking for?
That's why I was asking earlier on, we were following, just that you not expand. I wish that all of you were looking at what you are presenting.
I don't have it.
I intentionally say partial because I'm looking at the report now. Big number of the resolution are called partial. There is partial, there is fully implemented, there is not yet implemented. You don't like it? You can send them again while I will jump you, go to Honorable Mamuta because you seem to have a report in front of you.
Thank you very much, Chair. My name is Taruma Watcher.
I will send you the measure.
Chair, maybe let me with honorable members and MEC. Chief. Yeah, Chair. Yeah, I think I've noted a lot of
Honorable Mabuja, you know you speak loud, but this time he's hearing everything that you say.
Yeah, Chair, I think we've had a lot of, I think to some extent, some good things. But I just want to know, MEC, what seem to be the challenges in the department? Okay. What seems to be the challenges? Where do you think that in the next coming years and stuff, this is where we have a problem, this is what you're doing to try and circumvent those problems? Because we don't want a situation where we're going to be confronted with problems. We must find ways of dealing with the problems before they raise their faces. The next thing that I want to speak to, Chair, is that there's a huge interest in some of your facilities, more especially the academic perspective. I think, Chair, maybe in future, the government must just make it a habit of just giving us an update about the progress that's happening in the academic hospitals and other hospitals that they are currently busy with. So because people ask us questions and we're able to answer them properly. So if we are regularly updated. Now, the other issue that I have, Chair, got a lot, is that we spoke to, I think the HOD tried to touch on it, but she didn't expand much on it. Because she was giving a high-level brief, is that we said we want a system whereby the department is going to be digital, more especially patients. When I'm in Sheo and I get sick in Messina, the doctors in Messina must have the same notes as the doctors in Sheo. So maybe if you can just take us through with that already. is this part of your plans, and how far are you with this? And then you also spoke about the machines, those big machines that we see when we do our oversights. Not only laundry machines, there are machines in the kitchen. Some of those machines are brand new. Those machines, some of them, you were using steam to utilize those machines. You got them, they are still new, sealed. They are not working because you have changed from steam to electricity. So what's going to happen to those machines? And then there's on program 1 on administration change. Is that your department's collection?
Just hold there.
Okay.
Can you stick to the resolution?
Okay, no, it's fine. Okay, no,
Please, if you deal with resolution, and the second part is dealing with quarter 2 and quarter 3.
okay, no.
These are the questions that they needed to sort them out after we took the decision. So please don't enter.
I thought you had some of the issues that are already
So they
in the quarters, but yeah, it's fine. I will limit myself to those few questions, and then I will come back again. Thank you, Chair.
Thank you very much. Take the budget.
Thank you, Chair. Blessed day to you, Chair, and honorable members, and team Department of Health. Chair, mine today will be something different. We requested you to go and do things, and we are seated listening to something very different, and that is comforting. Yes, with an exception of yet to be achieved, in progress, but Chair, for me it's comforting because it says what we have said to you as a portfolio committee and see and your team, we see it happening, Chair, and really happening tangibly so. But what we'll also advise is that move with speed, particularly to areas that we can quickly deal with HOD. Move with speed just on behalf of the people of this province. So by the end of the next financial year, we'll be seated and we'll be saying, okay, this is what you said to us, to targets, we have reached all of those targets. But for me, Chair, today, I think we are on the right track, and let's keep it like that. Thank you, Chair.
Yeah, thanks, Modulasetulo. Re ke dumedishe maloko a committee ka moka, Honorable MEC and the team from the department. We were meeting here, Chairperson, when there is a family from which stays 7 kilometers from Helen France Hospital. Ke batho ba ga Sephoka ba eleng gore ba lla ka di conditions tša ko Helen France. The food is undercooked. They waited for 2 hours to get an ambulance which never came, and they had to hire a metered taxi. After paying for that metered taxi, the hospital refused to prioritize the patient, an old woman who is critically ill, because she did not come with an ambulance, which they waited for 2 hours for it to come. And they are not happy with the treatment they got from the staff. I'm raising this as a preamble, yes. It's very important because it's trending on social media. They send a message to us. But going to the resolution is very important for the MEC to note it with the HOD. Yes, yes. The multi-sector team, I think, were amongst the people who proposed that there should be such a team on teenage pregnancy. And we are told that everything is done within Expo approved. I don't know if perhaps it was not necessary to source some inputs from this committee, because the members here have various expertise and skills. They might have contributed differently. We note on the immunization program that vaccines are out of stock. Can't you explore the possibility of training people or identifying people who can do vaccines. Perhaps we become the first province to develop our own vaccines, because it has long-term implications on this under 1 year kids and so forth. And everybody who was...
I want you to assist me.
Yes.
Resolution.
Chair, I'm responding. The department will
Because
peptide if you missed it.
I just wanted you to pay attention, because I think we have an opportunity to deal with a number of issues. Unless we say, no, you are...
No, you are being unfair, Chairperson. If I may pause and ask the HOD.
I'm not stopping you, I'm just
She
saying...
spoke on immunization, on the resolutions, yes.
You are at work.
I'm on the
Just say
resolutions.
be aware
Yes.
that you can still have an ample time to deal with that, linking it with the actual key performance area that talks about.
Let me continue
Go
with
ahead,
the
go
opportunity you
ahead,
gave me,
but no-
Chairperson. Thank you. I'm going to continue. We appreciate the work done on, please explore that on vaccines. We appreciate the work done on engaging the state attorney. But my fear, MEC, is that you are celebrating that somebody has been assigned to help the department. You communicate with that person directly. But I can tell you now that one person is 1 out of 6. That's what they have in the whole province. Perhaps maybe going up to Mpumalanga. It's one person assigned to the department, but that person might be assigned to 5 other departments. So the person is not going to cope. You either prioritize dealing with these matters of medical legal cases in-house aggressively, so with the efforts you have initiated of engaging other legal personnel beyond your reach. The issue of the renal unit, I'm going to touch on it here, Chair, because we got complaints every day. Our elders are living in pain because the department is prioritizing young people, kids and so forth on people who must be serviced under the renal unit. So it means and that is because we no longer have specialists and we don't have those machines, and the department is spending on machines. We'll appreciate if they can prioritize that unit in particular. On the issue of paupers, of course, we know the report given here, but the department maybe must tell us how many diseased persons are on the list of paupers and what were the efforts undertaken to inform communities at large to say, please locate here if there is your relative. As I'm going to land, the issue of EMS training, we've been complaining about that we need to train more people and upgrade their skills, those who are in the system. But I hear that there is one college which is in Gauteng, which is going to be utilized. Does it mean that our FET colleges and locally in the province, we don't have institutions which are offering those skills to an extent that you go and get people in Gauteng to come and open a branch locally? Please look into that. And lastly, as we speak about routers and so forth, during COVID-19, the department procured cell phones and routers, and we gave them to community health workers and so forth. Where are those devices? Because they can still help where there is shortage. And HOD will know we are much interested if they've made any progress in terms of identifying old schools which can be used by the department for various activities. And lastly, but did you manage to pay people who are on acting capacity, and how many were paid to date? Were they paid backdated and so forth? Because those posts are funded and these people have overworked for the department. And you have lots of security companies which have been appointed, and you tell us that cables go missing and all that. How do you then deal with the recovery? Do you find these security companies, or does the department ignore the fact that you are spending millions on paying people to monitor your facilities and things are stolen in your facilities? We want to know what then becomes the role of security companies when cables and any other thing is stolen from the hospital, because they can't just be paid and be paid even when work is not done properly. Thanks, Chair. Agri will come back. Yes, yes.
We have interjected you earlier because of problem of we sent you many report, but I just sent you the next one, the one that is brief and go to the point. While you are still looking, I wonder if you will be coming back to respond. Assist in I see say not yet. Remember the workshop that we had. What was the month?
September.
That's it. About accreditation. I can see here you say it's not implemented. I don't want to behave by it. But I see in January 2026. We don't want you to problematize you here. The last 2 months. Just for us to get why you are. You remember we were careful not to raise the alarm in that direction. Because we are one when we were at the workshop when we found that work was on time. Expectation was that we give attention after that meeting. And that attention is the detail we give so that we must not say nothing and then from last year. You want to come later?
That's fine, Chair, carry on. I will go through it when I get it. It's not coming through for some reason. I will then, if necessary, submit written questions.
On your second point, related infrastructure upgrading and maintenance at the EMS and nursing college. With regard to EMS, you are saying work completed. I just want to check on that. What I'm reading is what the bill says about that. In the meantime, please come take a mic and respond to a few questions that we asked.
Should we come in? Thank you. Thank you, Chairperson. I think I'll hand over to the team. I'll come after if you need to come back.
Thank you, Honorable
Careful,
Chair.
that mic next to me does not assist us.
Oh.
It only assist other people.
Oh,
It's not for us to hear. You must just raise your voice a bit.
okay. Noted. I said I will hand over to the team and I'll come back after HOD.
Thank you, Honorable Chair. Maybe I could just speak to the one that you raised now. Now that is for Petersburg Hospital only. It was for Petersburg. Petersburg Hospital EMS College completed, fully implemented. The nursing college is the one that they were still working on some issues. Okay. Thank you. And then I'm going to, me and the team will be responding the issue of accreditation. Dr. Dibakwane will respond to. Maybe I could just ask the team to respond on each issues that has been raised by the team. So maybe we can start with Mr. Mawasha on issues of security, payment of acting positions, and then Dr. Dombo, issue of devices. All schools, we have identified 2, maybe I could respond to that one quickly. We have identified 2, wherein we have written now to the Department of Public Works some time back, and as soon as we get the response, we've been doing follow-up. As soon as we get the response, then we'll will get moving in terms of the renovations that are required. And then maybe also to respond to the issue of EMS training, Gauteng. So there isn't any campus that in Limpopo that deals with EMS training or even have a curriculum. Even our universities, they don't have that curriculum. So the Gauteng, they are not coming to set up their own college in Limpopo. We are going to be, the satellite will be training in our own facility, while our curriculum, which Dr. Dibakwane will give the update on where we are in terms of that curriculum. Mr. Mawasha, also to respond to the issue of state attorney, and then the kitchen machines, Dr. Dombe and Mr. Ramawa could respond to that one. And we are, thank you for the advice to move on with speed. We are going to do that. And then Mr. Mawasha also to speak on the issue of the system in terms of his centralized hospital information system. And then we have noted that when we come in, we will give those reports in terms of the other infrastructure, especially the new facilities like the academic and other new hospitals that are being done in our province. So I'll hand over to Mr. Mawasha first.
Thank you. HOD. Good afternoon, Chair, directors, members. The first one is whether we're going to have a system that will enable us to track patients from one hospital to the other. The question is yes, we will. Perhaps what we will do, Chair, is to submit to this committee some sort of plan on the implementation process. We've been busy doing some benchmarking after having failed to procure through the CT. So we've been doing this benchmarking with a number of departments of health in the country, and we're going to see an updated version of the current system we are using. So just when we were about to finalize the report, we got a request from other companies to make presentations. So we're finalizing a report on the benchmarking, and then we'll make a decision on how we proceed to get to procure or secure that system. So that's where we are right now. Then there was a matter of the state attorney, office of the state attorney. We said we have been assigned a person by the Solicitor General. This is not a person to deal with all our matters. It is a senior official to attend to the matter we reported here that we intended to take on the office of the Solicitor General on the losses we've made due to the problems they cost us, let me put it that way. So there's a senior official assigned to engage with us on resolving that matter. We said we were following the Intergovernmental Framework Act to say why shouldn't we claim all the monies we are losing as a result of the problems we are experiencing. So this one person is the one person to deal with that matter. There are still attorneys in the office of the state attorney who are dealing with our cases. So I just wanted to clarify that. Chair, we are paying acting allowances to employees that are acting on vacant funded posts. And I think this is the report we gave in the past. And we don't want to we should not be found to have misled this committee. We are not saying there's not a single person acting that is not paid. There are people that are acting and not paid because they are acting in vacant, unfunded positions. I think, Chair, we explained this in the past. So there are people that are in funded positions are being paid acting allowances as a position.
We can give you a report on the numbers. We do not have it. Security companies working for health get penalized when we do inspections and we find they are not living up to the service level agreement. And that is what we do. We take them on, we penalize them, and it escalates to a point where companies can be dismissed. So if there are breaches and we investigate the breach and we find negligence on the part of the company, it is part of the service level agreement that they can actually be penalized, they can actually be dismissed depending on the seriousness of the infraction. So people don't just get paid because they are hired and they're not doing the work that they're supposed to do. Yeah, thanks, Chairperson. Those are, I think, the areas that I was asking.
Doctor, you can go on.
Good afternoon, Chairperson and the committee. The cell phones that were procured during COVID and issued to community health workers, they are still with the community health workers.
Good afternoon, Chairperson and committee members. When it comes to EMS training, when we had the meeting with stakeholders in September, we had reported that we submitted a letter of intent to HPCSA. We received their response. The committee sat on the 11th of September and resolved that they are supporting us in terms of training of higher certificating emergency care program. So after that, then we will send all the requirements in terms of curriculum development, health technology that is required. So that is what the principal of the college and the staff they are busy with now. I think the HOD addressed the issues of why are we working with Lebanon. We are working with Lebanon because locally there is none. And we are also working with them because it takes a minimum, they reported that it can take a minimum of 36 months to get accreditation. But in the meantime, we want to be a satellite, meaning that we share lecturers as honorary lecturers, and that we start with the training on our side. What has happened now is that we are accredited as a continuous professional development provider. We will be now training for BLS and intermediate life support, ILS. We are busy also with the emergency training so that our colleagues can then be able to train. So training of the trainer, so that every healthcare professional in every facility can be able to provide that. So that has been work that has been happening in terms of training under EMS. And the issues of the renal unit in the province currently, we are providing chronic renal dialysis at Pietersburg Hospital. We have 3 nephrologists, accessibility shortcuts, and 2 of our regional hospitals, Chilizini and Letaba. They are also going to provide dialysis. Currently at Chilizini, we are at 100%. We have purchased 10 dialysis machine, which we are going to operationalize in the 1st of May. So everything has been done, and then the tower will be the second one, which is going to be in the 2nd quarter. So that is with regard to renal dialysis. Thank you.
Thank you, Chairperson. On the members, on the issue of kitchen equipment that were not connected, most of, I can say almost 99% of the equipment that we have seen when we are doing oversight, they've been connected in the FED program. The challenge was at the main, we had to do electrical upgrades, but that has been attended in the whole provinces I'm talking about. I don't think we'll have any kitchen equipment that is not connected by the end of this financial year. Where it's steam, and there's no steam anymore, we'll relocate to a facility that is steam and exchange. But 99% of all our kitchen equipment, they've been connected in this sort. Thank you, Chair.
Maybe I could also add that we have noted the issues raised with regard to EMS response time and Helen France conditions of food. So we have noted that it's something that we're going to investigate and address those issues. The first issue, the first question that came in, what are the challenges? I think it's difficult just to speak without thinking about it because it's a very general question. It's difficult.
It's fine. You, of course, members were encouraged to ask, but the reality is that you gain progress in following a number of issues. If you were to count them without counting their sub, out of the 25, so all of about 23 there is working. So the interaction was to understand, which means we're still going to have to, as the department, to give us progress with regard to this. I could not stop members from asking, but for sure we are F1 with regard to, we can't dismiss that work is not done, but it's working. But there is, before the Honorable Law come in, there is this issue of the labor on the matter. Can you just describe it differently? What is that? Are you working to make sure that at the end of the day you have capacity? And what tools are you using to do that? Is it a memorandum of understanding or whatever, the tools that are available in government to want to assist? I just want to understand properly. Someone can say, no, they have outsourced that. So it's important that at this platform now, we understand it and appreciate the initiative to want to start something. But we must understand it the same way as yourself. Thank you.
No, thank you. HOD.
So it will be a memorandum of understanding that we will be filling. So it's a twinning, I would say it's a twinning process wherein we are a satellite campus. Our own staff teaches, our people there, lecturers come and also teaches, and our lecturers go and teach that. So we sort of twin, we learn, but we are able to now train because we are now accredited. Without waiting for our own process to be completed, we can start training because they are accredited.
Use their license.
Yes, as their satellite campus.
Yeah, thanks, Honorable Chairperson. Just two things quickly. That the phones are still with community health workers. I hope they've been absorbed in the department or they are still in the department doing something. On penalties imposed, we appreciate that, but please help us with the report so that we know in this particular clinic or college or hospital, this is what was lost, this is the penalty which was imposed and so forth. Lastly, next time meet Department of Public Works before you come here because it's like some other arrangement just to comply that. we are going to see Public Works. It was going to be better if you met them before, so that when you come here, you tell us if you are going to take those projects from them because they've been stuck, or if you are going to do them on your own. Because now it's like, it's just a report, so we are going to meet them. Then if tomorrow you don't agree, where this committee could have given a different input in terms of advising what might be the way forward out of the frustrations we have with Public Works. Thanks, Chair.
Yeah, I think we may have to come back, but for sure you will understand we wanted to, we were at the, we call it grassroots, at the platform of your agents that are serving our people. And this question that you are responding, we wanted to use the way of seeking truth from fact, because we understand the reality. And we are saying we can't pass, if I can use the word, we can't pass judgment for now because you did not finish. But we wanted you to understand that. So that we are at one, as you come back, you take us from where we were left. But for now, you can speak to the matter that's raised by Honorable Law, or note that, and after you responded, Honorable Member will be ready for the second substantive items of the quotas. Yeah.
No, thanks, Chair. We note what Honorable Leboko has said in terms of meeting before we come here with progress. We'll definitely do that. And in terms of the CHWs, they still have the phones. They are still with us as the department, and those with matric are absorbed, and the other categories are still with us and getting that stipend that we are giving them on a monthly basis. Thank you.
Yes, 2,000 something, or what is the number?
2,000.
Where did I get the 2,000? What is it?
The ones that are absorbed 2,800
something.
Yes.
Okay. Who told me? Maybe you have said it the other time. All right, honorable members, can we go to the next item? We have received the report which is a progress, and honorable it's refreshing because the department decided to tell us the real status. So, although somewhere you needed to polish the intervention you are making, on your main document, item number 4, it's not clear there what you are saying. Or maybe I don't understand. I'm not saying come back to it. With regard to what we call progress on implementation of the resolution. We'll have an opportunity to panel it so that we understand it one time we read as the portfolio committee. Just to avoid to ask you multiple questions. The best is to answer in advance to the question that you know will ask you. That is the best. I was moving to the next part. I'm stopped by
just saying, you see this progress that we are getting. I think one of the contributing factors is that it's no longer Hollywood that side. Things are changing.
Okay. I will tell you next time why I agree with you. Because by the attention of the portfolio to see the whole department.
Honorable Macho almost chased them.
Yeah, we wanted to see the picture of the whole department. We have seen the response in terms of staff. We don't want to make comment now because we are saying it's progress, but we know our stand with regard to that. You know very well. If you can begin to enter in the vacancy, we will not finish this discussion. But thank you very much, Honorable MEC and your team, as well as honorable members. Let's go to the next item, which is the briefing on the second quarter performance report. And Honorable MEC, the floor is yours.
Thank you. I'll hand over to HOD to hand over to the person who will be presenting.
Dr. Mwango will take us through the reports.
Good afternoon, Honorable Chair and members of the committee. I'll be taking you through the two reports, second quarter as well as the third quarter performance of the department. So, this is the overall performance of the department. You will remember that in the first quarter we didn't do well. We were sitting at 50% overall performance on the APP, but now in the second quarter we had improved to 80.5%. You will see there that out of 40 targets we had managed to achieve 29. We only failed to achieve 8. So that's why now we were sitting at overall performance of 80.5%. So now I will take you through the detailed report in terms of the programs. Program 1, which is administration, well, this was just an update in terms of the addressing AG findings. At the end of the second quarter, we had actually developed an edit action plan, and we had started already trying to resolve some of the findings that AG had made. We had actually resolved 9 out of 15 findings. So we're actually remaining with 8 findings, of which 2 of them were ICT findings. So in terms of other indicators in Program 1, we had performed well. You will also see that in terms of revenue collection, we were at 70.6 million, when the target was 60.3 million. Otherwise, in terms of expenditure for the program, we were actually doing well. We were actually almost, we were 49% overall. So you'll be aware that by the second quarter, we're supposed to be 50%. So the program had done well in terms of expenditure. So we'll now go to Program 2, which is District Health Services. In this program, we will just highlight some of the areas that we were still having challenges with, which of course we were having interventions that we needed to carry out so that we can improve. The first indicator there being PHC mental disorders treatment with new. Just to say that we still have challenges in terms of having to diagnose some of these conditions, but overall we had identified that our clinicians were not coding properly, but we had to make some interventions so that we can correct that. In terms of adult remaining care rate, we had improved. You will see there that we are now sitting at 90%, which is improvement from the previous quarter, but we were still below the target of 95%. And the challenge was still non-adherence to treatment by our patients, but other than that, we had resolved to ensure that we strengthen our collaboration with other stakeholders so that we can improve. Another area wherein we didn't do well is in terms of adult viral load suppression. Although we had improved, but we were still below the target of 95%. We managed to achieve 86.9%. You will see that it was actually a good improvement from the previous quarter, but the challenge was still the fact that some patients were still not adhering to treatment. So the issue was to say that we need to strengthen the collaborations with other stakeholders so that we can improve. The same challenge we had with child viral suppression, we didn't achieve. But as you can see there, we had improved from the previous quarter. We were at 93.8% for the second quarter, and the challenge there, of course, was the poor psychosocial support. And as part of our intervention was to also ensure that our clinicians make sure that they actually adopt the child so that they can be good adherence to treatment. So other indicators, we were actually doing very well. There was good improvement. Another indicator that we didn't do well in this program was TB rifampicin-resistant MDR treatment start. We had actually planned to start around 63 patients, but we only managed to start 29 patients on treatment. And the reason for that was, poor implementation of our TB nucleic acid amplification test. But otherwise, we hope that in the next quarter we will do well. The other indicator that we didn't do well was couple year protection rate. Our target there was 60%, and our performance was 59.8%. It was not so far from the target, but it was still below. But the main issue there was low uptake of certain forms of contraceptives. So we needed to continue to market those other contraceptives amongst our patients. Another indicator that we didn't do well in this program was mother postnatal visit within 6 days rate. We were at 92.9% when the target was 97%. So we didn't do well. Otherwise, we then, of course, resolved to strengthen adherence to maternal standards. And the other indicator that we didn't do well was immunization under 1 year coverage. We were sitting at 71.5%, which is below the target of 76%. So as alluded before by the HOD, the issue here was the vaccine stock out from the suppliers. But of course, we resolved that as soon as we get the supplies, we needed to then conduct vaccination catch-up drives. Another indicator that we didn't do well was MR second dose 1 year coverage. We were at 80% when the target is 85%. So the same reason applies here, that of vaccine stockouts. So in terms of malaria case fatality rate, this was just to give progress. We were sitting at 1.74%, which was actually above target. Our target is less than 1%, so we were not doing well. So the issue being that we had 3 patients who died of malaria. The reason being that they presented late to our facilities. But overall, in terms of expenditure for the program was sitting at 45.89%, which was, of course, below the target of 50%. So the main areas that we have challenged the program was, of course, COE, as well as machinery and equipment, as well as goods and services. But we had remedial actions that needed to be done to ensure that we speed up the expenditure. So we'll go now to program 3, which is EMS. So in this program, overall, we are still doing very well. As you see there that we are still above the target of 85%. For the EMS P1 urban response under 30, we were sitting at 97%. For rural response under 60, we were sitting at 98.6%. We are still doing very well in terms of response in our EMS fleet. In terms of expenditure on the program, we performed well as we were sitting on target at 50%. We'll now go to program 4, which is provincial hospital services. So in this program, of course, as the HOD also said, the majority of the indicators here are as a result of the committee saying that we must also report on them. So of course, the program managed to achieve all the programs as you can see there, all the indicators as you can see there. Maternal death in facility, we only had 6 maternal deaths in the whole quarter. In terms of diarrhea death under 5, we only had 1. Pneumonia death under 5, we had 6. We only didn't perform well in malnutrition cases because we had 4 deaths and our target was 3. So the plan there, of course, was to ensure that we mitigate against that. So we now go to still under program 4, regional hospitals, specialized hospitals. The performance was good in terms of the sub-program for the 2 indicators. So in terms of expenditure for the program was sitting at 45%. And the area that we're concerned, of course, it's goods and services, COE, as well as households, but otherwise we had some remedial action to ensure that we can improve expenditure over these line items. So we'll now move to program 5, which is central hospital services. The program overall also performed well, as you can see there. Maternal death, for the whole quarter, we only had 14. And in terms of diarrhea death under 5, we didn't have any death as a result of diarrhea. Pneumonia death, we only had 1. Severe acute malnutrition, we didn't have any death. And as well as death in facility under 5, we actually performed well. So overall, the program performed well. So in terms of expenditure, the program was sitting at 48%, which was fairly good. So we'll now go to program 6, just to give update, to say that the processes we're still going very well to ensure that we enroll the allocated number of slots. So everything so far was on track. Otherwise, in terms of expenditure, the program was sitting at 44%. In the areas that were of a challenge were goods and services, as well as households and COE. But of course, we had some remedial actions to ensure that we improve in terms of expenditure on this program. We'll now move to program 7, which is healthcare support services. Here, overall, we are still doing well in terms of ensuring that all the essential medicines are available in the depot, hospitals, as well as PHC. You will see there that in the depot, we're sitting at 85% when the target is 28. In the hospitals, we're sitting at 91 when the target is 83. So overall, we're doing very well. In the PHC, we were at 83% and the target was 82. So overall, we were doing very well. And the reason for that was the fact that there was availability of budget. In terms of expenditure, we're sitting at 44%. And the areas of concern, of course, was goods and services, as well as machinery and equipment. But we had put some remedial action to ensure that in the following quarter we perform well. So lastly, is program 8, which is health facilities management. Here is really to report on progress on the capital projects that we are embarking on. As you are aware that for the financial year, we had planned to do 5 projects. So in the second quarter, we had completed Malamulele 100%. It was only the other 4 projects, which are Elisras, FH Ordinal, the Terrain Clinic, and the other hybrid energy installations, wherein we were actually still not yet complete. So there is just to show that how was the progress in quarter 1 versus quarter 2. So there was a good progress in all of the projects otherwise. In terms of expenditure on the program was sitting at 65%, which was well above the target of 50%. So that's the end of the second quarter Chairperson.
Okay. Honourable members, you want him to go to the third quarter? No? Thank you. MEC can continue the third quarter.
Thank you, Chair.
Thank you, Chairperson. I will now take you through the third quarter performance report of the department. So So this is just the overall performance. You'll see that, of course, in the second quarter we're at 80.5. Now we were at 77%, which is still very good vis-a-vis the performance we had in the first quarter. So, of course, there were just one or two indicators that our program 2 didn't do well, but overall the performance is still good. But overall, we achieved 24 out of 40. We didn't achieve 7. So in terms of just to update the committee in terms of addressing the findings of AG, in the third quarter we have now resolved 13 out of 15 findings. We're at 87%, and we're simply remaining with 2 findings that relate to ICT replacement of legacy systems. Other than that, other indicators in program 1 were performed well. We see there that revenue collections was actually even better than the second quarter. We had 70.2 million versus the target of 52.2 million. In terms of expenditure, the program was very expanded very well at 76%, which is above the target of 75%. So program 2 will just highlight the areas that we didn't really do well, wherein of course we had made some interventions. PXC mental disorders, although we were still not performing well, but there was sort of an uptick a little bit. We had 0.02. We were still attending to those challenges of recording as well as other issues that are affecting this indicator through our local area managers. Of course, in terms of adult remaining care rate, we had shown some improvement. We're now at 91.7%. If you can compare with the previous quarter, of course, we had improved, and the challenge was still the same of non-adherence to treatment by our patients. Adult viral load suppression, we had improved compared to the second quarter. We were now at 90.5%. In the second quarter, we were 86%. So we're still having a challenge, but of course, we're improving. In terms of number of drug-sensitive TB treatment start 5 years and older, we had planned to start 2,330 patients. We only managed to start 2,221. The issue being that we couldn't initiate the numbers that we had planned, and the reason, of course, was challenges with our TB testing. In terms of TB rifampicin-resistant MDR treatment start, we had planned to start 63. We only managed 82, but otherwise it was an improvement from the previous quarter, but we were still below the target. And those are some of the challenges that we had, and we had made some interventions. We hope that in the last quarter we will see some improvement. So another indicator that we were not doing well, we didn't do well, of course, is couple-year protection rate. We were sitting at 55.10% when the target is 60%. And of course, here the issue now was inadequate stock of oral contraceptives, and we had sought assistance from NDOH. So another area that we actually didn't do well was around MR second dose 1 year coverage. We were now sitting at 74.4, and we were still having the same challenge of vaccine stockouts, but other than that, we had done well with the immunization under 1 year coverage, but we were still struggling with MR second dose. So in terms of malaria case fatality, we were still not doing well otherwise. The same challenge of patients coming to our facilities a bit late, and we planned, of course, to have some awareness campaigns so that patients can know, the signs and symptoms of malaria. In terms of expenditure on the program fairly performed well at 69.7%. Of course, it was still below the target, but the areas that we were actually worried about were COE, as well as of machinery and equipment, but of course we resolved to speed up some of the advertisements of posts so that we can fill up those posts and ensure that purchase orders that are currently issued in machinery equipment are actually done quickly so that we can catch up in terms of expenditure. Program 3, we were still doing very well, even better than the second quarter. You will see that in terms of EMS P1 urgent response under 30, we were at 98. EMS P1 rural response, we were 97.5. So actually, the program is still doing very well. In terms of expenditure, we were at 72.9%, and it's just machinery and equipment that sort of dragged us down, as well as goods and services, but otherwise remedial actions were put in place to ensure that we improve. In terms of program 4, we were overall doing well in this program. You will see that maternal death and facility were only at 3 maternal deaths in the regional hospitals. Area wherein we didn't do well is direct death under 5, we had 5 deaths. And the reason for that was delays in patients coming to our facilities. But with pneumonia death, we were actually better. We had 4, where the target was 7. And of course, even in terms of malnutrition, we did very well, as well as death in facility under 5. Specialty hospitals, specialized hospitals, we performed well in all the indicators. So overall, the program expenditure was sitting at 67.2%, and the areas that we actually not doing well was goods and services, as well as households, but otherwise we had some actions to ensure that we improve. Program 5, we also performed well. You will see that in terms of maternal death, we only had 6 for the quarter. But perhaps one area wherein we, of course, didn't do well is patient safety incident disclosure rate. We were sitting at 79.7% when the target was 90%. So majority of these incidences, the moment they come late in the month, sometimes we struggle to close them in time. So other indicators in the program we performed very well. In terms of expenditure, we're sitting at 21%, and some areas that we needed to improve on was goods and services as well as machinery and equipment. Program 6, just to update progress, here the processes for ensuring that we register the students, they were still going very well. Here we're looking at selection of candidates for the academic year, which was planned for January. So, but otherwise, in terms of expenditure, the program was sitting at 16%. The areas that we needed to work on were, of course, COE, as well as goods and services. Program 7, in terms of availability of essential medicines, we're still doing very well. You see that in the depot, we're sitting at 84%. In the hospital, we're sitting at 88%. And in the PHC, we're sitting at 82%. So we're still doing very well, even compared with the second quarter. In terms of expenditure, we're sitting at 69% in the areas that we needed to focus on were goods and services, as well as machinery and equipment. And the last program, which is infrastructure, the status, of course, did not change much in terms of completion. We were still having Malamulele Hospital, wherein we had fully completed the project. We were still having 4 not yet completed, but it was just to report progress. You will see that, of course, in terms of progress with all these projects, the progress was good. Although perhaps not by a big margin, but that's where we had some issues with poor contractor performance that were being raised. But I think as we report in the last quarter, of course, you will see that there has been a very good performance, and of course the projects were actually doing very well. But otherwise, in the third quarter, this was the picture that we had. In terms of expenditure of the program, the expenditure was still very good at 74% overall. I think issues of COE, the issues that the program was dealing with, so that it can also improve, so that at least there was improvement in terms of expenditure. So that was the last report, Chairperson.
Thank you very much, Honorable MEC and your team. Honorable members, the two reports were presented to you so that you can be able to do your work with regard to interacting with the department on the basis of accountability. And also, you members are ready to engage with the report. Just here next to me.
Thank you, Chairperson, and thank you for the department for the presentations. I have some serious concerns though. There is some massive underspending in the programs, okay? We should be on 75% plus standing at the moment with spending, and some are down to 60, 62, 63. And that is concerning because we also have massive overspending. Massive overspending on machinery and equipment. Now, I can't correlate the two, and I don't know how we're getting that right. So either on the machinery and equipment, you budgeted very, very badly, and you fell short, or you've overspent and taken that money from another program. Because when you are spending more than 50% over your budget, that money must come from somewhere. Because you've got a budget and you have to work in the constraints of that budget. So I want to know where that money was taken from. Apart from the fact that you should never be overspending in a budget, unless it's an emergency, number one. Number two, that then it means environments have taken place. And I want to know environments have gone from where to where. How did we manage to overspend to that degree? You talk about a revenue collection of 70.2. Now, where is that revenue collection coming from? Is it coming from patients? Is it coming from medical aids? Is it coming from RAF? Where is it coming from? Because it's important that we assess that. We need to know, are patients paying? Why are they not paying? Where is this money coming from? And where do efforts have to be concentrated on? We get a report, program by program, which is great. I want to see a comprehensive program as the department in a total. Not program 1 to program 2. Let's get this department failed, achieved this as a total, and failed this as a total. I think that's become very important. Now, I have a very, very big concern about mental health patients. And I'm finding it heartbreaking. I'm finding it seriously, seriously distressing. Yeah, what's it, Hayani? Mopo did not meet standard. The 3, where we've got mental health facility patients, did not meet standards. Which means that our mental health patients, they are patients, they are human, they have got diseases, they have got issues, are outrightly being ignored or treated exceptionally badly, and I want to know why. Why is it that because they've got a different kind of problem to everybody else, that they are being subjected to this kind of appalling behavior and poor hospitals? It really, really disturbs me tremendously. The decline in immunization of under ones is seriously disturbing. I'm not sure if you are aware of it, I hope you are, because you are a Department of Health, that there is a massive measles outbreak in the United Kingdom and other areas of the world that has caused many a death and many a problem. There is also an outbreak of meningitis, serious meningitis. We've already had one case in Polokwane of that meningitis. Now I hear it's because there is a shortage of stock. Well, what did you do about it? Who did we approach to get the stock? Did we actually even talk to the Minister of Health? And if so, can I have evidence of that? Because you can't just say, we didn't immunize because we didn't have stock for 6 months. I want to know what you did about getting that stock. I want to know who was approached, and I want to know why there was a stock outage or a stock shortage. Because these are things we must address at a national level. It's unacceptable. We are not going to sit by and watch our children get sick and die because they couldn't get vaccinated. It's not going to happen. Let me tell you that right now. I looked at your high target achievements on EMS. I just closed the page and moved over. Because quite frankly, this is a portfolio, and you all know that is extremely active. We are on the ground doing unannounced oversights all the time. And I promise you this. There is no way that you achieve those high targets in EMS. So I don't know who's trying to fool who, because we go to the hospital. And every hospital we go to and every clinic we go to, we check the ambulances, we check the crews, we check their turnaround times, we check what the issues are with EMS, and the reality on the ground is not the reality in your report. It genuinely is not. I don't know why we're going this route. I don't know if you, and you will have to excuse my French here, Chairperson, there's an expression that says bullshit baffles brains. This nonsense does not baffle us. We are out there. We are on the ground. We are witnessing the reality of the patients in our clinics and hospitals month in and month out. You cannot pull the wool over our eyes. The situation at the tertiary hospitals is also seriously disturbing. Our 2 highly specialized hospitals, the 2 highly specialized hospitals that we have do not meet standards. Our tertiary hospitals, according to the report, do not meet standards. How is that possible? How is that possible? And where did they fail? On cleanliness, on safety, on waiting times, and surgery backlogs. I don't know about the rest of my colleagues on this portfolio. I get calls morning, noon, and night about people who have laid in beds for weeks on end waiting for surgery, or who are left in casualties days on end just waiting for a bed but require surgeries. When I phone the hospital, we can't help. We don't have specialists. Why don't we have specialists? I'll tell you why. Because our specialists don't want to work in those facilities under those conditions. I wouldn't either. There is a thing called medico-legal claims. When something goes wrong, they are responsible, but very often it's not their fault. And my next question with regards to medico-legal claims is, and we know you've lost 5 cases, and I mean that's horrifying alone. You lose 5 cases. The state attorney costs us 10.3 million. There were 6 cases. The state attorney cost us 10.3 million. 5 cases we lost. The claims of those 5 cases were 8.9 million to be paid out. The state attorney cost us more than the claims. And this week, last week, in the High Court here in Polokwane, you lost a case in the Donald Fraser Hospital. Much higher than this. Much higher than this. A pregnant woman who had gone through all the stages. She'd gone to her 2 clinics. She had gone to every single stage that she should have. She got gestational diabetes, she got attended to, she put on the weight, she was fine. But the one recommendation in that entire report was that her baby was very, very big and she was too small to deliver a baby that size. When she went into labour, and she was then partially induced, into the Donald Fraser Hospital, she was forced to deliver that baby naturally. She suffered severe injuries, severe injuries. Her bladder was damaged, everything was damaged. She had ended up having 4 or 5 surgeries. The baby had to be operated on immediately after he was born because of broken shoulders, dislocated bones, and severe injuries of being forced. Despite the fact that on file it was clear that that baby was too big and she should never have had a natural birth. Now my question is this, you've lost the case, you're going to pay. Good, we should. But what has happened to the staff in these cases? What is happening? Who is being held responsible for these medical legal claims? The 2 nurses involved in there, and by this way, they delivered that baby without a doctor present, should have been dismissed on the spot. I guarantee you I will go to that hospital and find them still there. After they cause such pain and such suffering, I'd be embarrassed. I would really, really be embarrassed. The lack of expenditure, particularly in critical areas on the PSI, which is your regional hospitals, they do specialized services. But we're not spending. We're not using the budget. I'll leave it there, Chair, because I know that my colleagues were also involved in this, and my anger level is just hopped through the ceiling, so I'll leave it here before you take me to the Ethics Committee.
Well, we think there's a metaphor we want you to emphasize a point, and I don't see any problem. So, Honorable Walk, you are now in the right platform.
No, I think even earlier, Chair, it's you who accorded me an opportunity to interact with the report, so I was not lost basically. Hence I paid my attention to only issues which were raised, but along the way we might add other issues which are important to society. Like now, just to, as I'll be going through the issues, to ask the department 2 issues. One is in relation to vaccines, shortage and availability. That there is this confusion and public outcry in terms of the quality of vaccines. And I wanted to check how does the department, or does the department have quality assurance steps to ensure that these vaccines which are given to our people are very safe for long-term use, so that you don't find us being stuck in a situation where pharmaceutical companies use our people as test tools for their vaccines trials and so forth, and later on these cases come back and they are part of medical legal cases, and these vaccines have caused complications and so forth. So it might be an issue which not everyone might see immediately, but like if you check the global space in terms of health debates, those are some of the issues which are raised time and again. And the department must explore that area with interest, so that we don't just take vaccines because somebody which is funded by the same pharmaceutical companies said you can use this vaccine. So we need to be advanced and ahead. And sometimes you'll find, Chair, that in our space, if you have an opportunity to look up there, if you interact with nature, you will sometimes see that there are some chemtrails, we call them chemical trails, being emitted by some aeroplanes. We inhale those things, and ultimately the state which must be responsible. So the department must check for us if that is safe, because in other countries, those things have been banned. But in Limpopo and all over South Africa, you see those lines daily. So we'll get back to the business of what has been presented quickly. So it was important to raise those issues so that the department check. Chair, I think we raised the issue of Bas Pogawako Brookman. The department said they are going to look into that and many other issues. And
EMS.
Yes, with regard to EMS response and quality of food, because undercooked food carries bacteria and worms, and that causes problems.
EMS did not come on time.
Yes, I think the HOD captured it with the team. They took 2 hours, and if you check Brookman to then France is about 7 kilometers, right? So it relates to similar incidents experienced by other members right here in town. The ambulance couldn't reach there. So we are raising these issues so that the leadership of the department zooms into the type of and the quality of reports which you are given. Because people might give you reports which contradicts the reality on the ground. Honorable Chairperson, the revenue collection strategy by the department, I'm worried because on the revenue collection, it includes ordinary people, the indigents, SASSA beneficiaries and so forth. Those people are made to pay in our hospitals, and we can't be proud to collect money from people who receive social grants for them to survive, whilst they are even subjected to expensive municipal bills, be it electricity and other services. So the department must mainly focus on other routes, including medical aids, making the elite to pay and so forth, so that we exempt completely these poor people, because the narrative that is optional or we don't push them back, it ends up making people to be reluctant to go to hospital, because you don't know the attitude of your admin people there when somebody does not have money to retrieve the file and so forth. So that must be looked into. And to also say, we will appreciate and we submit here that at the end of this current term of security guards, please start exploring means to absorb all the security people to make sure that the process of insourcing kicks in. You can't have security tenders permanently. You can hire these people, it will save the department more, and you invest in your infrastructure, processes and other things in the department which are important. Chairperson, the medical legal cases where legal costs are at 10 million and the victims or patients claimed 8.3 million, and you ask yourself, was it necessary to then go to court? Because you spend 10 million defending a case and you pay almost that 10 million to the victims. What did this legal firms or whoever was involved do with this case? How long did this case drag? Because if it's so few cases, I think it's 10 cases or less. So it means this case have been in and out of court, or there were a lot of consultations. Perhaps we'll get clarity as to what happened. 460 cases enrolled on medical legal cases, and how many are outstanding? Because it's 466, but how many are outstanding which must be enrolled with the courts? We need to get clarity on that. The issue of targets on immunization, I think they touched on it and indicating that there was shortage, but shortage of medicine generally. Just make sure that you have people who check continuously if there is medication in all your facilities, because sometimes you get calls. I will forward some messages to the NEC, and she is very quick to respond and make follow-ups. But it would be nicer just to have your people to check. Whoever is supplying you with medicine, Are they able to supply it on time? Is this medication enough to run for a particular period as per your plan and so forth? So that people don't go back and forth and get frustrated in health facilities. And I think at one stage we requested a detailed report. We'll repeat it in terms of medical legal cases, so that we are able to sit as a committee, even if the department is not there, to say we have a problem in Seshego Hospital, and these are the doctors who are always involved when there are this type of cases or any other institution. I don't remember us reviewing that report. We'll appreciate if we get it. The department needs to be aggressive in terms of dealing with recruitment of nurses, because we have shortage. Skilled people are now on pension, and you might have to call some of them because you are struggling. You find people complaining that they are overworked. There is a rotation of personnel because we are trying to balance this and that. Sometimes we even do that rotation without proper letters to say you are now redeployed or assigned to this facility. And it has a lot of labor implications. If something happens to that person in the other facility, you may not have answers of what to do in that regard. And you will note, unless if there are changes, Sekhukhune College, to our knowledge, is deregistered, unless if you have done some magic after we received that information. So there is not going to be any Sekhukhune Nursing College as we are sitting chair because of failure to comply with certain requirements in terms of the bodies which regulate the industry. You presented there on your report, and there are four domains which affected your performance. People complain about waiting time in hospitals. That is the reality. And the patient safety is another feature which affected your performance as the department, the cleanliness of these facilities. And the cleanliness, it means you either you don't have sufficient staff, or I don't know, perhaps you outsourced, but you need to focus on that, because the cleanliness then is hygiene, it affects everything in that environment. So please zoom into that space of those outstanding domains. They are very important. I raised it twice in our interactions that this thing of waiting time, it affects our people badly. Some end up sleeping in the benches, or school taking them out, they sleep in some corners. And they only got 10 rand to get to hospital. So we proposed previously, Chair, that the department must consider introducing a process to say, if you stay more than 2 hours or 3 hours, we are going to give you a meal, a lunch, because our people are starving there, waiting for the whole day. There is no doctor, this and that, because we don't have specialists which are refusing actually to come and work in the province. Because MEC, what one idea more yeah, idea anywhere in the country. That's why specialists are now doing more. Yeah, Shuma elsewhere. That thing but you never cover. And also some of the management in hospitals refusing to procure machinery which will help the specialists do their work. So please look into that, so that we can attract more specialists back to our province, and it will deal with the Tabayadi waiting period and so forth. So that thing we're raising of the domains affects 3 out of 5 regional hospitals. So it's a very big issue which must be attended to. We still submit here and we demand it. We want all clinics to operate for 24 hours. And unless if you can give us a different answer, because we have security in all clinics, 24 hours, security is being paid. So you can't pay security 24 hours just to look for a building, Yellow is closed. Let's have nurses working there. This security must take care of our nurses and our communities. And we can't afford to have that. We were appealing again, decentralization of postmortem services is affecting our communities badly, and we need progress in terms of that. Even if that Lodox machine is expensive, the department must go get others and train more people, because the little that you have, they are forever exhausted. They are trying share. But please come on board and simplify their work. Decentralize their services is affecting our communities badly. We appreciate the initiatives in terms of improving the renal units, Chair. The intervention they are making in Chelezini, you would understand if they say 10 machines, because their reports will tell you that in that area, there are a lot of people who are requiring such services. Perhaps it's because the state is still failing to regulate traditional medicines and the dosage and so forth. Yes, we have asked the Premier to come on board, and in particular the department must regulate that space, advise our people how to mix those things, because we can't live without nature. We need holistic health care. So our people are not going to be forced to go Western pharmaceutical only, but there must be an intervention in that regard so that we don't have a lot of people requiring that service of dialysis and so forth. The Seshego Zone 1 clinic, we are not going to give up on that. And Tatarama, please build that clinic, because the community is suffering and you find a lot of people who go Spetlele and Zone 4. We need that clinic. The community is fighting us on that clinic. And the answers we have given. No, yes, the MEC is taking.
You are asking Papa.
He knows why I'm asking, because now I think they are on a program. The Premier spoke about building of clinic center. I hope that one is on the list, because we have been asking on behalf of the community, MEC. No, they will have to tell us if it's included. And if it's not included, they must make means that we get that clinic. Donation and so forth. So I think I go back and more. Popular clinic, even in other areas. I think there was an issue we raised, which relates to nurses. That at one stage, nurses complained that they are not allowed to study further if they want to do masters, Kobo University of Limpopo and other universities. Despite having 4 years diplomas and degrees, they were not actually accredited to study there. The nursing science and so forth. So we will appreciate if we get feedback on that. We raised it several times here. Modern college, you will remember, Chairperson, the principal had complained not to the driver students. And we have not to date seen post-study driver based for the nursing colleges and so forth, which affects the whole operation the nursing colleges. And on your equipment and machineries, please do consider buying those CPR dolls or mannequins, because we have seen old ones, and technology has moved. And our people are stuck there with those things. We press us all. I get that thing is a piece and but for medical use. So you know, but if I move the you have seen it, those people who went there, and I was so shocked to you have those old things there, and it's a problem. I think we touched on, we need the exact number of student intake, given the developments. You are not accredited here, or deregistration of colleges and so forth, so that we know or more the nursing college, or those lecturers are just going to be there. The ambulance indicators, I think you'll have to revisit them, given the realities that we have presented here of people who were not helped. The last thing, when is the department going to introduce the process, Turkey and so forth? You might raise revenue, they are willing to pay those people. So if you introduce them here at home, they will pay. BBL and everything, liposuction, those cosmetic surgeries and so forth. So those people have money, the state must capitalize on that. We need those services here, and the poor, of course, will be subsidized by those who can afford. We need those services. No. They will pay. They are going to take, imagine how much is the flight and all that. And now our America, our people are stuck here. But on that point, the state must have a list of people who are doing those things. You know why? Because later on, when there are complications, they come to public hospitals. They are going to add on the medical legal bills. And you will not take note, you will not have a record that this person went to some country to do these procedures, and it's the state which is going to be responsible. Hence, it will be wise for the state to even introduce that process here in Limpopo and possibly in the whole country. Thanks, Chair.
Yeah. I wanted you to speak up, Sister Nick, but anyway.
Okay. Thank you very much, Chair.
I must speak after the.
Yeah, I wanted somebody, an elder, to speak after or before I call Honorable Mahmoud.
I think you should do that.
Okay.
Yeah, before I call him, because they ask a lot of questions and they ask everything. Yeah, so if they were playing football, they were just going to play the ball alone and then pass it to the next person and then go and score and come and defend. They are very good anyway. I was a ball juggler myself. I've traveled the whole ground as well. So thank you very much, Comrade Chair, and greetings to the MEC and the staff complement, the HOD. You are called now departmental head. Yes, let me know the HOD. I think so. Greetings to all of you. It's unfortunate that I was going out in and out. My family were outside, so I had to also deal with that. It's important to balance family and work. So it's very, very important. So my apologies for the chairperson. I don't have many questions so much, especially that I didn't get everything, but I went through the reports, so we appreciate the reports that were given. And most of the questions were asked by Honorable Rojo. I just want to ask them differently so that, to make emphasis on issues of clinics, on the pronouncement that we're going to build clinics. The last time we built clinics, I remember it's a long time ago. I was still in the RDP and there was a moratorium. I don't know whether there were other programs, so one was following that, where we were replacing visiting points with full-fledged clinics. There are other villages, including where I come from, where there's no clinic, and there's still a visiting point where I will not even look at when I pass, in terms of also the development in the area, which is quite high. It's like you are now in a town when you are in that area, but we're still having a visiting point which will only cater for those who can just go and collect some ARVs and so on and nothing else, and with no service going on. So I want to check as to what is the criteria of building a clinic, because it is everywhere else except where an honorable is staying, and obviously we don't speak for ourselves. We always speak for others. Maybe that is the criteria that was used in the past, so this time around we are being made to run. So please tell us the criteria, whether it's kilometers or the city population. I'm not more sure whether it's 3 kilometer radius or 5 kilometer radius or 5,000 population or whatever. So I need to be clarified on that so that the community can also make a follow-up on their own in terms of also being on the station wagon of those programs that are going to be implemented, including clarifying why the one, if that criteria will also assist the clinic in Sishiko for it to be built and other clinics. I think that was one I also, you remember I had that question before. The second one, I think you also asked it, that I wanted to deal with because we have just absorbed people into the system as student nurses, and we were there in Sikukune, we saw everything, we understand that indeed there were challenges, and this time around there were even national Department of Health, and now we don't even have a license to really proceed. So what is now happening with the intakes that we've just taken now? Where are they being trained, and then then how are we doing about that, and what is the follow-up in terms of us having a license. I remember we met those that are dealing with issuing of licenses at the ranch, and they were definitely indicating issues, so we also need to deal with that, to be updated in terms of what are the issues that make us to be having this type of problems in our province. I don't think I have a lot. I already indicated that I'm happy with your responses, but yeah, let me rest it there. The Elim story, I think, is an ongoing project that you're dealing with. I just hope that you're dealing with that. Honorable Mabucha will deal with that. We've been there as well, and we know, you know about the mortuaries there. We were told they are doing some team work there. We just hope that it's fine. My child had to come and give birth in Seshego. So she had to come over to Polokwane to give birth. And want to appreciate Seshego Hospital because they did a very good work. And I had to go there, and on the first day when the baby was born and I was there, my child was walking, and because there was no any other place around our area where she was supposed to give birth. It was a normal birth. She wanted to give a normal delivery, and she was told she can't. So she came to here and she was referred to Seshego, and we want to appreciate the good work that Seshego Hospital is doing. Honorable MEC, we've been there, we visited the hospital ourselves, we've seen it, they are okay, we've seen the staff, the commitment, and so on. I think they can complain, and I understand that other areas are also, there's a lot of influx of people coming to that hospital, and I believe you're also able to deal with that. Even other that was about to go to other hospitals, they're going there. So this issue of a clinic also will assist to remove some of the pressure that are there in that hospital. So yeah, that is all what I wanted to say. I don't think I have a lot. Thank you very much, Chairperson. Thank you, Honorable Members. Yeah.
Thank you, Chairperson.
Let me agree to the rest of the deputy chair of the day. I will come in after Honorable Mabucha.
You will sweep. Thank you very much, Chair. Chair, one, I think that it's very important that sometimes our province must be innovative. We can't keep on following what other provinces are doing.
And this is irritating me.
She's getting better, but it's hot.
Keep it on, please.
Yeah, keep it on.
It's fine now.
Comrade Chair, through you are, you know I don't write, I'm an old type of...
You'll come back.
No, it's more one thing.
Okay.
He asked the question about why our people are not allowed. My question is, specialists are not allowed to work in their private. I want to turn it around. Is it only us, or other provinces are not doing that? If it is only us, why?
Okay, I understand because otherwise, that's the point they are moving out if it's not the same. The conditions are not the same.
Yes, thanks, Chair. I'm making this point because we know our people want this cosmetic surgeries. And Gauteng has responded, like the call of nature, they've responded positively. Yeah. If you want to do a breast reduction and excision of lipoma, you pay 35,000 there in Krisani Barabana hospitals. And if I want to go and do a tummy tuck or tummy tuck, I will pay 35,000 as well. And then there's a whole list of them and prices. So it can't be a strange thing for Limpopo to do that, because even the people of Limpopo, sometimes our bodies, you see me, I look like an amoeba, cheapless. But we've got doctors who can do this thing in other provinces. Our people flock to other provinces, others international, to go and get these procedures that we can do them in the province and at the same time enhance the revenue of our province, because the specialists are there. Now, so we are calling upon the department for the policeman. Let us come up with these things. It's not a taboo to do these things. Our people need them. Now,
and then you will say what you're very special.
yes, we're getting
The
there.
basic one.
We're going there.
Okay.
Chair, I mentioned earlier on when you cut me, I was talking to the issue of the department giving us constant reports regarding these hospitals that they are building. Remember when we went, I think it's Chilizini, where we were told that there's a plan, actually it's approved, but it's stuck somewhere, whereby they are going to build them a new hospital. But the process is stuck somewhere at head office or national office. So they made a clearing call to us that please go and unlock whatever red tape that is there, because this hospital is bad. So we want the department to, whenever they think of coming to visit us, they must know that there is a question about how far are we in terms of constructing that hospital. Because the CEO of the hospital can't tell us or no, there's a plan that has been approved, just stuck somewhere. And then the senior management here doesn't know about that. So we are humbly pleading with them that next time, every time when they meet us, they must tell us, no, it's approved. They are going to do some training, and we're inviting the portfolio committee to come and join us. And then the other thing, Chair, it's on the response rate of EMS. You know, we can put this to the test. One day, MEC, or you don't use your name as MEC, we call an ambulance somewhere in town, not far, just in town, and start timing them on how soon are these people going to respond. Because our people want effective service delivery. They must not have service delivery by name. They want to see that this service delivery. If we can call Netcare 911, they will come there within 10 minutes. But if you call EMS, we've got more ambulance than those people by Netcare. But call them or call whichever private ambulance company. They respond very fast. But call our own EMS. They will take forever. They will take forever. So it shows that the problem is not the problem is in the system. The problem is in the culture. So we need to find ways of changing that culture so that our people can know about the technology that we are using. Maybe it's failing us. So we need to find this 30 minutes is still not enough. A person can die in 30 minutes. And 60 minutes in a rural area, it's a lot. So we need to find effective ways of ensuring that the emergency medical care are able to respond very fast. And then the other thing, that dynamically, you might find that there is one ambulance that is broken. If the ambulance is broken and it's supposed to be my shift, I can't use Ilwoni's ambulance, therefore just stay there and answer the phone. That thing, I don't think that it's going to assist our people in getting the emergency treatment that they so need. Now, on specialists and RWOPs, and then you see on this one, Chair, I think one day MEC, you must bring your people that developed this policy, and you must also invite your doctors to come in, because whenever we go to hospital, they'll whisper in our ears, well, this is a problem. The reason why specialists are leaving, and the reason why they're not in training, we are planning to leave, we're in the departure launch, is because this thing here, it's only implemented in Limpopo. Doctors get posts in Limpopo because they're desperate, and other professions, but I know doctors, they get this, you appoint them, and then they also apply in other provinces. Mpumalanga, Gauteng. Once they get affirmed in other provinces, they are quick to dump us. And you say you've got a policy that is going to save us money, but is it really going to help preserve the lives of our people? Is it going to assist us in reducing the long backlog, surgical backlog that we have in the province? Is it going to reduce the long patient waiting time for surgery? Because we can have a police, but how effective is it in terms of assisting our people? How is it in terms of improving your staff morale? We can't always have people who can't wait to leave your employment. It means you are a toxic employer. So we are saying to you, MEC, have a frank discussion with your staff there in all corners, from your allied services until your heads there. Well, okay, let's have a discussion around this. Because the other issue that they have with this Arab surplus is that it has got eyes. This one has it, this one doesn't have it. Therefore, if they don't, then what they will do, they will leave. We went to any hospital. We found a young woman there, very energetic, saying, well, look, you see this queue here, there's no way that I can handle it, because these people want an orthopedic, that one of the knees and what. They said the orthopedics here, they resigned. They went to other areas because there are issues between the department and them. So they decided, well, let's leave. Now, once those people resign, that one can perform that operation. Those doctors that are in training, they can perform that operation. So that's why I'm saying that there is a need for the department to go and look at this. Well, okay, how we have got this policy, but is it really assisting our people? I know HOD is going to have a different view about it because he wants to save money but our people are not getting this specialist. Our specialists are leaving. Maybe as part of the response, maybe the MEC must tell us how many, ever since she came into office, we don't have to take it far, ever since she came into office, how many specialists were there and how many specialists are there now? Do we have now? How many have resigned? How many has she been able to recruit into the system? Now, there is this other one, Mailucha shift system. Leona MEC, you have advertised posts for this medical officers. If you can just take us through. You appoint them and then they get into the system because they are desperate. Once Gauteng appoints them, they resign from Limpopo and go to Gauteng and other provinces. So it's a problem. So on the training, program 6, our nursing colleges. Yes, we have seen that the department has issued an intention to recruit more nursing students. But why are we not seeing the same with EMS? Because we are lucky. There are ambulances that are there, but we don't have this EMS. And you know, not all of us would want to be doctors and teachers and what. Other people want to be EMS, others want to be nurses. So we need to make sure that we bring back these services. We train more and more. We rather go and feed other provinces, MEC. We need to ensure that we train this EMS and nurses. One colleague of mine mentioned, we went to that college there, I'm not sure what is it, nursing college there, where there is a lot of containers. Yes, we do. You know, the security said to us, yes, we are here, we are security. But Kakwa Marauka were able to patrol at night because there are no lights. So then you then get to wonder, okay, if this one's don't have lights, and there is constant looting from that side where there is, the securities can't go because they can't even see, it's very dark. What about other institutions that have got similar problems, whereby the facilities don't have lights? So we're saying to you, please go and look at your facilities, make it a point here, when you hire security, security must be enabled to execute their duties efficiently. Because if not, they can't see. So it means that that area is unguarded, and therefore it's vulnerable. Anytime anything can happen. And then I want to enter into, you see today we've got a problem of diesel and petrol. It's a problem. I just want to check, or what if we have a similar situation whereby it's not about diesel and petrol, and then we have a problem about medical supplies. Our vaccines, there's that thing of foot and mouth, what. But what if the one country that is supplying us has a problem of wars and whatever a conflict that might arise? Do we have enough supplies that will be able to cater for our people for at least 12 months when things are starting to take shape, or when we look for another country that will be our next supply? Or are we trying to build capacity in our province? Because I can remember, with plans and build something in a department that they manufacture these things, the medical supplies. No, I'm telling you, now, in the portfolio that Honorable Martin chairs, the social development, there's a problem whereby social development, it was not a problem anyhow. But then, health, in that space, it's not clear, its rules are not clearly defined. Because we know that when they take these substances, it affects them to some great extent, their mental well-being. So, what is the department doing to ensure that they work hand in hand with the Department of Social Development in dealing with this thing here, the drug abuse? What is it doing? Because there are a lot of this drug rehab centers, private, and I think they are the ones that are dealing with most of these cases. So now, they treat these kids of ours, these younger brothers of ours that are addicted to these substances. The people that treat them, some are not even medically accredited. They treat them by giving them certain things. Yeah, general knowledge. And the department, you'll never hear about the department is going to a particular year, they are going to check, are these people being treated properly? So we're just saying, maybe tap into that space. And then, Chair, the Premier made an announcement that they are going to encourage, or the people who want to go on pension aid, there is a fund that has been made available, they can exit the system. We've got a problem of nurses, whereby nurses exit the system. After exiting the system, their posts, they were acting for a very long time, they are not filled in time. So the Premier has made that announcement, and the Ministry of Finance has also spoken to it, or their funds are there, they are going to release the funds. Now, the department, you know you are going to be one of the department that is going to be heavily affected by this, because your people are going to take that option, and then our people are going to suffer. So, with this announcement, are there plans in place to ensure that you recruit more and more, you fill in these vacant positions in hospitals. There are a lot in hospitals. Are you going to fill them over? This announcement that the MEC of Treasure is going to cripple us even further and further. Thank you very much, Chair.
And you know that it's misunderstood.
Yes.
Thank you, Chair, and blessed day again. Chair, for me, if you want things to be done different, we must approach things very different. And I think in the case of the Department of Health, it's dealing with a whole lot of issues. Issues that are affecting our people, particularly those people that do not have luxury of taking out a medical aid and saying, I'm going to ReadyMed, I'm going to medical. And I'll tell you what, Chair, when I'm sitting here and listening, there's a lot of members that have raised this issue quick response or non-response emergency medical vehicles. And I remember one year, if it's not last year or so, there was a big launch of about 100 or 200 ambulances or so. Now, what I would want us to do is a proposal from the committee. We'll take it back and decide to implement or not. We do this. There's a lot of clinics, Chair, that whether we like it or not, in this current financial year, we'll never have them to be ideal clinics. Whether we like it or not. And the beginning of wisdom is when we call things by names. We audit those clinics. We go all around the province. Obviously, you know how many clinics are in the state. Maybe you categorize them in green, red, yellow. This is a challenge, this is not a challenge. And those ones, Chair, that really, literally now we can't walk in and say we need services, because I clinic to become a deal, it needs a clinic manager, it needs this, it needs that, and ultimately a doctor or whatever that might be able to travel to that place. And we know, seated here, but there are those clinics that are not yet ready. Then the proposal, Chair, we can then ask as a portfolio committee what is to be done. Let's cluster those clinics. Let's check clinics that will not get ready in this financial year. If we put temporary closure, let's do that. And then go and work on maintenance. Or another Chair, no, you know, in this clinic, in Nangalwana, I will stop in this clinic and get in and get assistance. And how do we also get an ideal clinic HOD? We need staff complement. Do we have that in the province? Do we have enough nurses? Do we have enough doctors? We do that audit, we do that analysis, Chair. It will assist us to tell us as a province, where is our challenge on the whole report? How do we then attain certain clinics in the immediate, becoming 24 hours? How many clinics can we then say in the next financial year, we are still working on those clinics? How do we then say, so we call things by their real names. Because if we sit here, Chair, every portfolio committee, okay, how many clinics are we going to get as 24 hours? Are we really going to get all clinics at 24 hours in one financial year? The answer is no. So let's not feed our people dreams. We must tell them the truth. We must say, okay, this financial year, Honorable Chair, we're going to have 12 clinics as 24 hours, ideal clinics, in all districts in the province. Then, we temporarily put them down. We maintain and make sure we are able to go there for services. And then number two, there is a lot of unemployed graduates in the province. A lot. I've seen, Chair, doctors were striking there that they are unemployed. Let's not talk about those ones that are leaving. Let's talk about, remember the health, it's a calling, Chair. Health is a calling. We should be empathetic more than anything else. And Limpopo being a rural province, there's money that we can pay that Gauteng is able to pay. So if we are going to look at how much I'm earning if I'm working in Limpopo and how much I'm working in Gauteng, we'll end up not having any specialists in the province, because really, with the limited resources, we can't be able to pay those medical officials, Chair. Then we do that. We have a University of Limpopo here, but it's training doctors. Where are those doctors that are trained by our own government? Most of them are attending academic class. Where are they checked? Why don't we check how many unemployed people do we have in the province? Those ones that have expertise, medicine, in terms of agriculture, these people that we love so much, they're specialists. Let's check how many do we have in the province that we can recruit into the department, MEC, and make sure that we fill this staff component that rather than arena level. And once we do that analysis check, we'll be able to say, let me now as a portfolio committee, we look rhetoric. Because we say, okay, how many clinics are we going to open in the next financial year? Say, no, we will open. How do we have in the next quarter, in June? How do we have to October, how the year is gone? What have we done now? But we must agree as a portfolio committee and yourselves as the department, MEC and HOD, or how many clinics can we get to an ideal status clinic, honestly. Then when we come to a portfolio committee chair, we sit and say, okay, on those 12 clinics that we said we'll get them to ideal status, how far are we? Then once we are done with the 12, then we look at the entire value chain. It will assist us to move chain. And we really need to know, it's very important, we know it's very important. Our communities, remember we are the mouthpiece of our communities. Or no, the hospital is coming at this level, chair, at least we now know, from the Department of Health, we're going to get good stories emanating from that. At the most cuts of it all, chair, that is very important. The people that are looking for this government for help on a daily basis. I don't look at the middle class. I look at the poor and the downtrodden masses of these people. How do we assist them? We assist them by getting an intergovernmental relation process moving, where let's talk about clinics. You get your local municipality updating its indigent register and giving it to the Department of Health. The Department of Health then distributes it to the hospitals and the clinics and that. You know, no, I do not have money. Before leaving Sekisha, because you get nurses and administrators that are so rude that you don't even know, are these people working in health? Because once I'm sick, I come to the hospital, it means already my life is paid. I'm not fine. But then when I see tools, no, but you need 100 grams. I do not have it. How do you then ascertain that a Kiribone area does not have that 100 funds? Whereas you can just punch and you say, oh, no, but this is a grant, a SASA grant recipient. So, Chair, we really need to move on how we do things, and we see, and then we check how do we then revolutionize, because the world is moving. And if it's moving, we can't be left alone. And as a province that we are left, other provinces are moving differently. And that we should do very well. And to ascertain to our people, this government is here to protect your interests, to protect your health, and to make sure that, Lilena, you feel the fruits of this freedom that all of us are feeling, Chair. And the last one, Chair, that I wanted to speak to is with regards to the BBA. Honorable members where we must bring cosmetic procedures in our institutions. But those things, yes, they are good, they will give us revenue. But we do it at the state of our infrastructure. Which one are we going to say let's start with? So it's areas that, as and when our infrastructure is at the state of what we want to see, we can then look at all those innovatives on how do we revolutionize the province in terms of health. And Chair, that's where I stand, but I would like to then say, in the next portfolio committee meeting, let's do things differently. Before we get into this lot of English and reports, let's talk about what matters most. How many clinics do we have in the province that we can tell you to ideal clinics as a matter of agency? Then once we have that, Chair, we'll be able to be monitoring that we want to get for the people of this province, Chair. And I thank you very much.
Thank you very much. I've spoken more than the department time of presentation. But you are saying very important. I just from China. Came back over this weekend. I wish I can tell you about matters of time. I would really have to pay a loan that I used to go there. But one thing that I got there, I was sick when I was there. Then I was treated by traditional Chinese doctor. I know because I was in science, I wanted something
Yeah.
green. They just love it. The truth is the size, those are big. Also the force that I wanted to bring something. So they just use their own terms. And I thought they would touch my head, they said I touch it a bit.
Yeah.
After 2 hours, the whole of the sinus will stop. But the point is
So you
that
must
the
refer me to
the
the-
integration of if I was not cured, it was going to be easy for them to transfer me to the western part of the state. There, so I didn't have to go and call out. At one point, you got, if you can't be cured, this one are responsible to take.
Now you appreciate holistic.
But this was off the record. May I synthesize certain things here? I wish that HOD, as you deal with them, you are able to group those that belong to the same pillar or key performance area so that they must not go up and down. But there are trends that members have flowed out. One first trend that was raised by about 3 of them started by this is the financial trends related to expenditure patterns, where somewhere there is under expenditure, in particular in quarter 3 or 2, 4, 6, and 7, they were below the standard, but we go to the next one related to machinery in other areas. There is somewhere where there is extreme overspending and other things. Both quarters, and they are found in different key performance areas. For sure, it must be important that members are made to relax, because I think they raise it as a problem. But trends are important for sure, we all know, in terms of financial management, science, or what they call management science, which assisted all management to understand planning, leading, control, and organizing as a primary of management issues. That takes us also to the matter of using specialists and doctors, which is a matter really that must be responded thoroughly. We can assure it that management are on top of this matter. I'm not canceling the question, I just say it's important that we get certainty there. The other one which is raised as well is the issue of revenue that we are committing the department. But we also want certainty there on whether there is an effective system of doing so, so that it must not go up and down without good reason or with different reasons. I think it's very much important. What was raised about mental disorders, the department will say it was a misunderstanding. And members think it's a neglect. And it's important that we also put it in the right context so that we must not ask it again. And we will change and move forward to where I can go. We can ask the same question all the time. I think that's very much important. There is this issue of machinery equipment. We may not have time, but I think in all items of machinery, we may have to go further than say, what is it that you are doing? You spend so much or you did not spend. What is that you're supposed to, let's use the word, buy and you did not buy as you are not spending? Where you have spent, we may, as we go forward, enter into the details. What exactly is this? Because somewhere, 123% expenditure, which means the work has been done. What is that work? What are equipment that are there? I think I emphasize or want to synthesize that because we are now aware of the reality on the ground, including with regard to the machinery that are not there or those that are there. So it's important that as the expenditure happens, we are also taken on board to deal with. Honorable, 3 of them that are talking about the response time. And they are not saying the problem is call center. You may have to reconcile that. Because somewhere is a call center that is really routine. It's going there and coming back that side. is an assumption, but you may have to let us relax with regard to that. For sure, that call center is not outsourced. Because if it's outsourced and it's that way, you may not do anything. Or you will tell us if you may have to do that. The conversation about medical legal and the conversation from the state attorneys are calling for an intervention from both the department and the state attorney to work together, because they just put it clear that they have shortage of staff. But we know that the origin, the source of the case is not from them. The sources are from the department. So there are two things that must happen. We must deal with what costs us and the preventative measures that we must take. And also you check what is that they ask. Maybe they say the department they have capacity in terms of legal personas. They come there to prepare only their cases. Well, they were putting a way forward, but our other thing is the source. The increase of this thing may not be, if there were many, it was going to still cause problem. So I think it's a management responsibility to assist us with that. We want to reduce those problems. You can't be happy if one problem continues for 3 years and they say you are management, you are ready to plan it, but the issue continues and you don't worry. And as you leave it, there's no consequence of people who are ill or who are making those mistakes. I think very much important. We have invited us to the depot when in the past, honorable member will say you are privatizing your depot. You said no, you are not private. Sure you won't get tired in explaining it's not private, it's not private, we are not private, it's not no element of privatizing. Or if there is, you will be able to brief members so that they know on whether you are in charge of things or not. Yeah, I think that's very much important that we do this. You may have to go into detail about how you can't spend 3 years losing doctors and specialists and it's nothing that you are doing. Do that. Taking everything into consideration, the one that you are aware and you are not aware, but obviously you want to say this is what we try to do, but still does not work because of 1, 2, 3, 4, 5 as we continue. So that will assist us to, as we go in transition to receive the biggest hospital for our time that is being just there next to the stadium complex. The last one, these are not my original question, I just want to check in there. Honorable Wilson asked a question about certain 4 issues, patient safety and them, where there are 5 hospitals, 3 are not achievable, but you still achieve. So I think you may have to explain, because if you were a layman and 3 of the 5 are not achieving, so there's something wrong there. Although we have seen, I'm just asking for you to go to give certainty to that. The same goes to the special hospitals, where you have the 3 hospitals that are not doing in that regard, but you still achieve. I am sharing and well, but with regard to the achievement, you still have achieved what you want. Well, I think by saying 1 or 2 things, I've assisted you to do my request of making sure that you put them together, those that are related, so that we can be able to respond to all matters that are related to each other, so that the logic prevails and the integrated response can be understood in context. as the people who are working with those matters on a daily basis. And Honorable MEC, I think Honorable Shine, and before I do that, Honorable Ndaga.
Yeah, I've forgotten one thing on the issues of paupers burials. It's just a question and a suggestion. The letters were written, and there will be some responses at some point, sometime. We might not be sure when. And bodies are piling in hospitals. And the hospital is the one that is affected. So, is it not possible? The pain is with the department. The department must actually heal itself out of this pain by possibly assigning someone who works with the municipalities. And also, if it's a policy matter, getting the money from municipalities that was supposed to be dealing with paupers burials at national level to come to the department. But with the liaison, with staff now appointed within health sector who are dealing with paupers burial, or burying and claiming, which can never bear fruit. The budget must move from municipalities to the department, but with people seconded to municipalities to deal with the matter right there. If the budget is there, the department must be the one that second people to deal with this matter. It is just a suggestion. The letters will be written, and then bodies are piling up. Thank you. And maybe they can comment on that. I don't know the policy around that issue.
Yeah, there are three questions on policy that were raised. There is this, there is this issue, Honorable MEC, that is very popular. Rural health matter, where you have a group of your staff that have different capacities that you assist. Is there something that program deal with which if they can't do, we'll have a problem? And I know my question is not clear. Is there a backlog or is just a campaign that seeks to one to deal with the matter you are dealing with? You put it correctly. I just bring it out for you to come out that this is not a backlog, it's a program, it's scheduled existing and a standing program that will continue irrespective of whether we short this or not short. Honorable Wilson, you are doing well because you don't know if you are going to give you an opportunity to do follow-up labor. I'm not sure. What I'm thinking about is not to give you a...
It's done.
Mine is very quick, Chairperson.
Yeah.
Can I continue?
Yes, otherwise I will not be a chairperson.
Okay, it's very quick, and I know that the department will be unable to answer it now, but please may we request on behalf of the Portfolio Committee an urgent report with the breakdown of the facility revitalization grant, who the implementing agents are, what the projects are, project breakdowns, and budgets for all, please. We know you've got the grants, we need to know what they're being used for, and we need a breakdown of all information with regard to that, please. Thank you, Chair.
Thank you very much. Yeah, I think we are done with the question. Why must I be a change if I can't change mine? Or why must I be a brain if I can't change my mind? You know that the mind is working. Okay, you are on the floor of the MEC.
Thanks, Chair. HOD.
Thank you, Honorable Chair and members. We are going to respond to the questions that have been raised. The inputs we appreciate, we are noting. Those that we are able to do, and we will give a report if there are any challenges with regard to the inputs. Maybe I can just quickly take the one for RWAPs because it came a lot, which is remunerative work outside public service. Since 2018, I've been DDG tertiary and academic before I became acting HOD. Since 2018, we have never refused RWAPs on any person. As the members are talking, we are listening and wondering, what is this about? So we have even put, maybe just to stand, RWAPs is a national policy, it's not a departmental policy, it's a national policy. So we have even given a circulars to guide how people should apply and how often should apply, because by law, if a person applies and you don't respond within 30 days, it's deemed approved. That is by law. But as I stand here now, because we have now delineated everything, we have made sure that by the 31st of March, all of them have lapsed and we're issuing new ones. And as I'm talking to you now, I'm left with the last batch here that just came today, the last ones. Every person, not only specialists, every person who have applied and they have complied with the regulations. For example, if someone says they are going to do RWAPs, but they include official working hours, obviously that is not in compile. We can't approve that one. What we are aware as a department is that, specifically specialists, they want to leave public patients and go and operate on private patients or see during official hours. That, as a department, we have definitely put our foot down, and we are aware that we have lost specialists because of that. We have charged specialists who have left our patients dying while they go and operate outside. That we know there are people who are noted. We have never, since 2018, disapproved RWAPs of any person. And right now we are not only approving specialists. Members will be aware that we have been having a policy where we are not doing committed overtime. And the reason for that, we've talked of unemployed doctors. It's unethical that there are unemployed doctors, some of them very poor. So we have said overtime is for additional work. Instead of one person who is in taking that additional work, bring an unemployed doctor to take that additional work. That is all we have done as a province. And as a result, Limpopo province has employed more doctors than any other province, new doctors. It's true that obviously, because it's money, if they get a work in Gauteng with overtime, we have been monitoring to see how many are leaving, because some are leaving, but we still have many, many doctors who are unemployed. As I talk to you now, last week we have shortlisted, we have advertised 220 something posts of doctors who they have shortlisted last week, and they will be possibly interviewing this coming week or so, because we had to make that choice. I had a group of 160 doctors who were unemployed in my office. We were given 150 million by Treasury to appoint the doctors during that time, that first year when the crisis of unemployment. So I had to make a choice to say, do I employ more with no overtime or less with no overtime? I asked them to make that choice. So eventually, as a parent, I feel I rather employed more with no overtime. And that is all that Limpopo has done, which is different from other provinces. So we are approving RWAP. So if there are any rumors, it is not correct that we don't, and we have a different policy. The only different policy we have is we are opting to give additional work to an unemployed doctor rather than to give overtime, because that is committed overtime. It's additional work above your 40 hours. And we are aware that that has made us unpopular, but we are hoping eventually it will stabilize. We are monitoring that space. And that is not affecting specialists, because for now we don't have enough specialists. We still need them to do overtime. And in terms of the number of specialists, in the 23-24 financial year, we have appointed, I'll just give a number because I cannot be exact. We have appointed 100 specialists and maybe we lost another. We have appointed, let's say, 20 specialists and we lost 20 specialists. So at the end of the day, we were still in the same place. But in the last 24-25, we have started to notice a positive. We have appointed 20, maybe we lost 2. Our numbers increased. By the end of third quarter, we were already at 165, which we had never reached before. So we have been making strides in terms of specialists. We have not been losing specialists, at least in the last 12 to 18 months, 24 months. We have been steadily increasing the number of specialists. The people who are leaving, we hope they will also tell us the truth, but they are no longer many as compared to the past, to say what are the main reasons why they are leaving. Because as a developmental province, we are developing, we are waiting for Limpopo Central Hospital. We ask them, what do you need? We literally go to if we hear, sometimes we don't know, because what happens at facilities, at head office, we might not know. We are hoping that before a person chooses to leave, they will escalate that issue to the head office so that we can be aware, because we do make sure that we provide what they need. Machinery and equipment that we are talking about medical equipment which they require. So we will try by all means if we know, and we will humbly request if you hear anything, refer them to us, because it will assist us to know. We can't lose a specialist because we can't provide something. We are aware that we do have challenges, number of theaters, our own specialists. Those are the issues that we are aware. So that is the only one I wanted to just speak on, because it came on several times. Maybe the other one that I want to speak on is the EMS response time, but I'll ask Dr. Dibakwane to still speak to the EMS issue. We have commissioned a computer-aided dispatch where when we invited the members, it was for pharmaceutical warehousing and for CAD. The reason specifically where we invited is because the CAD system that we have put in place, it's supposed to tell us exactly where each ambulance is, what each EMS person is saying, which will impact even on the response time. As we are seated here, we are aware that it is not functioning optimally, and it's something that we want to get into to try and see if we can manage those issues. I think DDG can speak to it, but we have been trying to be there to be supportive of those issues that are not working, but we have noted, and we have also noted some of the issues that members talked about, calling an ambulance and not getting it on time. So there are plans to try and work on those issues so that it works. If it works optimally, even if there could be a delay, we are able to see it on the system because everything is mapped. Each person, each ambulance, they have gadgets that will tell us where they are, what they are doing, if they are en route. So I think with that, I will hand over I'll ask start with CFO to speak on issues of finance, revenue, as well as the over expenditure. Then everyone will respond to their matters. Thank you.
Thank you, Chairperson and honorable members, MEC, HOD. I just felt, tempted to add something on what the HOD has touched on. Limpopo Department of Health is one of the departments which has got what we call term contracts for medical equipment, which other provinces are tapping from. If you look at other provinces that are buying those equipment, they are buying because we've got the contracts in Limpopo, meaning that we wouldn't fail to provide those equipments to our, medical officers. We have been buying equipments on a yearly basis. Then coming to the issue of the financial trends, the spending trends that have been raised, I would like to indicate that, when you look at the spending trends in terms of the economic classification of our public sector budget, structure, definitely when you look at it from compensation of employee, you'll expect to have spent a certain percentage per quarter, like 25%, which on compensation, yes, we were a little bit, behind. That is why when we went to the window period for budget adjustment, there were certain amounts that were requested to be dropped down to goods and services, as well as certain amounts that were, given back to Treasury because of, the process of employment is not as fast as, the attrition. But coming to issues of capital.
You said they took money from you because of...
No, they didn't take money from us. When is, budget adjustment period, you have to be realistic in terms of whether you spend everything that you have been allocated. So a certain amount, because, on compensation of employees, suppose a person happens to depart on March or say on April, and you fill that position after 2 months, that 2 months is a real saving. Meaning that the person who's going to occupy that post is not going to get the salaries that you didn't pay for the past 2 months. It will remain as it is. So coming to the budget adjustment, you either drop it down to goods and services, or you repurpose that budget for projects that are once off, because you will still need it going to the next financial year. So those are the things that we have done. So you surrender it and request it to use it for something else, and they must give it back to you. That is how you need to manage the budget. But when it comes to the issue of capital-related projects, like machinery and equipment, like building and fixed structures, it doesn't follow the 12-month cycle kind of a trend. It follows the plan. Yes, you'll find that you have ordered the equipments, you anticipated to receive them at a certain time, but because now of the USA, Israel, what is happening in Iran, it affects those medical equipment to be delivered in time, and as a result of that, you delay in terms of now spending on that particular item. But as you press on, sometimes you end up being lucky, you get the equipment early. And when you get them, you need to pay. So as a result of that, you are even, expecting to spend more early than late on that particular, area of the budget. That is why when you look at capital, you end up, spending more sometime because of, the work that we've done earlier than expected. But at the end of the day, you still have to strike the balance to break even at the end of the financial year. And I'm saying this because at this point in time, when you look at our capital-related projects, we have break even at the end of the financial year. Though second, maybe third quarter, the expenditure was ups and down. But at the end, we push all the service providers to deliver what they promise, to make sure that we break even. So we do not have a problem in that particular respect. But coming to...
If you make a pre-planning, you can also spend prior to that.
Yes, you can. Because if you get all those, like now, if you look at the issues of the ambulances that we spoke about sometimes, those ambulances, we managed to order them prior to the beginning of the financial year. Because we knew that, that particular industry, everyone is looking at it, in the country. If you place your order in April, you run the risk of not, getting the delivery in time. So you end up being lucky, sometimes you get the delivery in the second quarter, whereas in terms of the budget cash flow, you will have staggered it until end of the financial year. So when you get it, in the second quarter, it doesn't mean that you can't pay. The budget is there. You have to process the payment. And it will then give you that, a spike in that particular period. Going to the revenue.
So you agree that sometimes if the portfolio say, tell us what you bought is important.
Yes.
So that we reconcile an explanation.
Correct. Coming to the revenue, we do have, the policy that govern, the health sector, as well as going to an extent of who is supposed to pay and what. Meaning that the issue of those that are indigenous are taken care of. Those who are unemployed are taken care of. Those that are earning a certain, amount and less than are taken care of in terms of the categories that have been agreed upon. And we don't, go to an extent of collecting or getting revenue from the poor at all, because they are subsidized by this government. That is why when you look at even the people who are at our institution of senior citizen and stuff like that, who are also benefiting from the grants, they don't pay. It's for free. But going to an extent of looking at, the issue of the system that we have in place of revenue collection, we do have a system. That is why when you look at the performance in terms of the current financial year, we have been doing quite well in terms of the target. Now we know very well that the target that have been set by our provincial treasury doesn't talk to the 100% of the debt book that we have. They look at the realistic target, which is informed by all the factors, depending on the province that we are operating from, because we are rural of the rural, and most of our people, you cannot deny them access to service. Even when they come and they still have a debt, you are still supposed to allow them to access the service. But where we are sitting in terms of the target, we are doing quite well. I think I'm covered.
Thank you, Chair, MC, and members. I think I picked up two from the Chair's synthesis. And one is a very simple one. It's about
I can hear you. I'm not sure if your colleague can hear you as well, because I'm looking at your mouth. Satisfy yourself that everyone hear you in the house.
Okay. I'm saying one, Chair, is about the voluntary exit program and the early retirement program. We just before we entered here, we're having a conversation on that one. We are busy finalizing the advert for those posts that have been exited. And the only requirement is we are not to use the savings from those posts. So we have, as the CFO just explained, we will be able to explain what we've done with the savings, but we are in a position to fill those posts. So an advert should be completed in the coming week to go out, in addition to the other adverts for other posts that we have been.
So you advertise in advance or after the fact?
No, okay. Chair, maybe because you have asked, let me also bring this. We have requested from Office of Premier and Treasurer to advertise all the posts that will be vacated by all people that are achieving voluntary retirement in the coming years. So even before they leave, we'll just do it in chunks of 3 months each. So we will advertise, because one of the problems we've been experiencing is underspending on COP. So we're trying to circumvent that. We will not win it completely, because even the processes at that level of finalizing recruitment plans are completed just before the financial year starts. Like he has said, you then naturally will lose about 2-3 months. But we will advertise posts even as people are in the post. That has been approved, so that when people leave immediately, others are able to come in. It will be so in respect of later in the year, but the early part of the year we've already kind of lost the time as he has already explained. Excuse me. The other one, Chair, is you pointed to the issue of the state attorney and us, the relationship. And I think it's a comment that we will note. It is work that we're busy with. Earlier when you said the Solicitor General appointed someone to deal with that particular matter, and the matter of us saying, why don't we sue you? I think if you look at the reason for it, it goes into the heart of all the problems that we have in the state. If we engage on that matter and we are able to solve, it will probably deal with all of the reasons why we are even embarking in that course. Non-attendance to court and so on and so forth. That was the second one. The next one related to it, you spoke about the causes of medico-legal matters. Dr. Yokwan will probably add on this. There are many things that we are doing, Chair, that are directed towards that. A lot of the things we've just been discussing, all these things about medical equipment, for instance, is part of addressing the systemic issues that will contribute to this. We're doing very well on medicine and medicine supply, which is also a contributory factor. But there are other issues, for instance, your patient-related costs that are very difficult, but we are working on them. Awareness, for instance, out there on some of the causes of adverse events. We must do that. We are busy doing it, and we are launching campaigns. The MEC has been hard at work on a number of the things that the community must be aware of that causes this problem. So there are quite a number of categories. I may have forgotten the third one, but my colleague will assist me. So there are obviously also systemic issues that relate to staff attitudes, competence, and so on in some cases. We're working hard on those issues. It will take time to resolve some of them, but we are hard at work. Thanks.
Chairperson, there was a question on the immunization that occurred as a result of the suppliers issue. Indeed, the supplier in August of 2025 wrote to the National Department of Health sector-wide procurement unit for medicines to alert them to the anticipated shortage of measles rubella vaccine, and so that letter was directed to the National Department of Health unit that deals with the procurement of medicines, and it was then copied to all the provinces as well, where they were then highlighting that particular challenge and also indicating the plan in terms of manufacturing, and that according to their letter, the certain units that were going to be arriving in September and November and January of 2026, and also highlighting, this also touches on a related question about who approves vaccines in the country. So the vaccines can only be released once they are approved by SAHPRA. So that is the body that is tasked with quality assuring and releasing vaccines for commercial distribution. So based on their anticipated processes in terms of the SAPRA process that can take up to 90 days for them to do that particular procedure. That is then how they informed national and the provinces in terms of the expected delivery of vaccines. So in terms of the vaccines that we received subsequent to that particular challenge, we started receiving our batches in December. So on the 10th of December, we received 10,500 units. On the 27th of February, another 10,000 units. On the 2nd of March, we received another 10,000 units. And on the 24th of March, we received 20,000 units. And as the units were arriving, we were then conducting our catch-up campaigns for those children that had missed the vaccines as a result of that particular stock-out. In terms of the surveillance of vaccines, SAPRA has got a vaccine safety surveillance committee, and equally there's also a procedure of adverse events following immunization. So any adverse event that happens following an immunization is reported all the way up to SAPRA, and so that is what is currently in place nationally and according to the presidents. So there is a clear and formal process of how vaccine-related issues are dealt with. Thank you.
Ideal clinic. Ideal clinic.
Yeah, a comment.
Before the next station, there is something
Thank you,
that
our very versatile chair. You know, Chair, I'm just picking up something. There's just some questions that don't need to be responded to verbally. Needs to be typed in, because in next meeting we'll be asking you the same thing. Say, no, but I did not present it like that. Those ones that are with us in the portfolio committee, they know what we want. Like, especially for questions that are a bit tedious. We are not undermining their level of intellect, but we are saying they should not respond. Tomorrow we bring it back, Chair, they say to us not like that. So I would propose, Chair, through you, that areas, questions that are a bit tedious, could we have them back, MEC, SS, just reports, detailed report. Don't go speak about things that we did not request. Like now, Chair, we've spoken about the vaccines. It's not what we need to hear, and it is what we must read and know and be able to internalize ourselves. And the second one, Chair, is the analysis of clinics that we requested through you, that we can address a report. How many clinics can we have a site in? So those are some, I think, some of the questions that they are responding to, Chair, really do not want to be responded to in need us to receive as a report. That is the proposal through you, Chair.
okay, you wanted the response to say it's like recently we will give you a report.
Yes, but then we give them timelines. So remember, we can't just say we need a report. Can say we need a, because it's clearly they have those answers.
Right.
If we can give them maybe a period of 5 days, they're able to respond to us, that would be highly appreciated. Thank you, Chair.
Okay. And I think it's noted, but you not say, they must not say something, but you must confirm that they're bringing it.
So they must confirm it in the vote.
All right, thank you. You're on the floor through your HOT and MEC, whoever is next.
Okay, Chair, it means on the issue of the ideal clinics as well, we'll give a report because it's going to be lengthy. Again, we do have clinics that has reached that status and others are not. So to avoid being long, we'll just provide a report.
This is we'll cut the meeting short.
No.
But it's fine, that's how
That
honorable members have asked. Well, mistaken is fine. But it is something that we needed to hear a bit, then say it and then do what I just said should happen. Otherwise, it will be like, You can't answer anything. Yeah.
Maybe the one we can respond to, I was just quickly screening. I think that many of the issues we may have to bring reports. Maybe the one that I can only speak to is the issue of cosmetic surgery.
Yes.
As at the moment, we currently have only one plastic surgery. Obviously, with only one plastic surgery, we are focusing on service delivery only. We can't even begin to think of anything else because of the numbers that we have. I think you just ask our MEC about the rural health matter. It is some of the backlogs are related to children who are born with these abnormalities that need to be corrected, and that plastic surgeon is busy with that. So that is the only issue that I could talk to. The others, I think we may have to provide reports. Okay, maybe I can explain something about the mental health and why we say we have achieved, yet there were issues that we were not compliant in terms of the actual patient experience of care survey. So what National Department has done, because these reports are at a national level, the indicators are at a national level. In the last financial year, they changed the indicator. In the past, we used to attend to exactly what you have questioned. We would have been non-compliant. That's what the indicator was. But the last financial year, for this financial year, they now have patient of experience of care survey rate. Just the fact that you have done that survey, then it means you are compliant, which definitely doesn't assist us in terms of what members were asking. We agree, we would have been non-compliant if we used the actual results of the survey. But what National wants and what the indicator needs, we have done the survey, it means we are compliant, we have achieved. And that's the issue, that's why there are differences.
Early, I don't know the other one, they tell us the new hospital. Maybe you can also talk.
So we have two facilities that are currently in construction. Is the Limpopo Central Hospital, is the Siloam Hospital. Siloam Hospital is almost complete. We are expecting that by September, according to the plans, the hospital will be fully complete, according to the things. Limpopo Central Hospital is at 38% construction. They are almost on target. Everything is going on well in that facility. There are two facilities that the planning phase has been done. Everything is intact. It's Chilizini Hospital and Elim Hospital. These two hospitals, everything is done. What is next now? We are supposed to go out on tender. We are not able to do that because there hasn't been any funds allocated to the facility. So the National Department of Health is currently now using the next window for the BFI to apply for funding. So there isn't any funding, that's the reason. So between National Department of Health and us, that's what we are waiting for, that allocation of funding from Treasury to start the facilities. That's the reason why they are still on hold.
Okay. Do you answer all the questions?
Except the one that we requested, the reports. Because if now when HOD is reporting, if we are to get deeper again, we'll say she's putting a timeline, a deadline for the operation of Siloam Hospital. And then we had it virtually, she did not sign it. On that day when it comes, it's not operational or it's not functional or open. We'll have a problem when the HOD say, no, but I did not speak to exact date. That's why Chair will request that reports that are especially timely, let's have them not virtual accurate. Thank you, Chair.
Fine, but I'm happy that they mentioned Elim Chilizini because people there, they talk like they are waiting any time to do stuff. But what she's saying clarify the fact that it's not budget for now. Yeah, you were still on the floor.
I was just quickly scanning. I think the other issues we will need to bring written responses.
You answer the Honorable Mdaga thing of the one that is dealing, what is the question? There is something talking about it.
Dr. Dombo?
We would also need to respond because the requirements are contained in a document that was published by the CSIR in terms of establishment of facilities for social services. So it's not just about health services. It's comprehensive.
So you're going to submit some.
Yeah, but Chair, just to add on that one, after that announcement already, moratorium has been lifted. We have started with the assessment as the department, because remember, as much as there's that criteria, we need to assess in terms of the province, how many new clinics would we need as the department, and so that we can be able to be assisted to say maybe on a financial year, how can Treasury assist us in terms of having funds to build, but they would need to know exactly how many we need and where. So we are just saying we are not sitting after that thing. We are busy conducting an assessment to assist us so that we can start knowing where exactly should we be building those clinics based on the criteria that Dr. Dombo will be sharing with the committee.
Okay, that's good. The fight at Nkwangwa related to security, will we get, is it true?
What?
If it's true, for sure sometimes we will have an opportunity to discuss.
It's the what?
About the community fighting over the security matters. You don't have to respond. If it's true, you can also do the same. With regards to the principles that is said.
You know, Honorable Chair, there were lots of issues around the issue of security. As you all know, that the term of office for the previous security service providers came to an end, and we had appointed new securities. So there were a little bit of tension and even wrong information that was moving around, but we had tried through our communication department to outline what had happened, because we had actually felt as the department that there were some ways of inciting a tribalism within the processes. So we went to an extent of trying to break down how many companies were appointed from which district, all per district, to show that everyone was covered. But what we are saying is that supply chain processes were followed and everything was done fairly. And we further ensured that we even meet with those service providers before they could even start working in the facilities, to say, yes, as the department, we cannot choose for you who to appoint, but in each and every village, there are stakeholders there. Meet with the stakeholders, outline the process, or how are you going to advertise, how are you going to appoint, so that there can be transparency. And from the report that we have, that has happened, and people were appointed according to what the service providers wanted, because at the end of the day, what we want as the department is for them to provide security so that we can continue giving those 24-hour services, knowing that our employees are safe in facilities and our patients are also safe.
Opportunism there, people want to take advantage of this, to bring tribal nationalism. If you have dealt with it, you may not need a report, as long as what you are telling us is fine. Yep. Where is that agenda? Do we have anything remaining? You can take out that hospital that we don't know its name. Which hospital is that?
Which one?
Well, I was talking about the picture. I thought because it's a health department, you are showing us a new model of the plan for hospital. But I know that what was to follow was an announcement. We dealt with all questions for sure. And yes, I don't normally announce. I ask people to tell me on whether there is an announcement. And she's tried very hard to want me to say it. I'm talking about this hospital. You can do the announcements.
Thanks, Honorable Chair. The only announcement is that there is lunch just outside. Well, it's not going to be lunch or whatever, but you are invited to have lunch with us. Thanks.
Okay. Thank you very much. I think it was a time well spent. This meeting was very fruitful. And we want to thank the department for the attempt to make sure that things are changing. And of course, well, we are considering on whether we should go unannounced or we should go with you. Earlier I was saying, if we deconsider it, is not wrong. It will be because we have brains. I was told that if we have a brain, sometimes we must change mind to show that the brain is working. We do so because we also want to enter the terrain of, as we go there, speak to some stakeholders, including your hospital board, to get their views and other things, or further than that. So it's not going to happen immediately. We are just saying it will happen. So for sure, all other resources that we have in interacting with people, you may have to accelerate them so that we get the real picture. We are not saying to Rama go and tell people the portfolio committees can, we don't want that. But we want to see the real picture, all of us, so that we can be able to function in a system that is alive, not dead. Thank you very much. We see a lot of members, the meeting is adjourned.
Thank you. Thank you, Chair.